benefit, and it was a positive for BFS response. And however, that was a subgroup analysis. So they conduct this phase 3 trial. Unfortunately, it was a negative trial and didn't show a benefit in OS, neither BFS, with a hazard ratio of OS 1 and BFS 0.97. And you can see among all of the subgroup analysis didn't gain any benefit of adding this novel medication. If we look to the second trial in the advanced pancreatic cancer that carries specific condition, which is code break 100, I think everyone familiar with this trial, phase 1-2 trial, recruiting a patient with a second line or third line and beyond that carry KRAS G12C mutation. They recruit around 40 patients, and they have at least one line of the therapy. Most of them, they receive at least two, around 80%, they receive 2 lines of the therapy. And it was single arm with adding to rosumab, which is one of the KRAS mutation, a reversible KRAS mutation, oral medication. And the primary endpoint of code break 100 was objective response rate. And it was presented in ASCO this year, and everyone aware that it was a positive with objective response rate of partial response around 20%, stable disease around 84%. Now, if we look to the PFS at 4 months and objective overall survival was around 7 months. There was a grade 3 toxicity in form of diarrhea and fatigue, as well as abdominal pain. However, there was no grade 4 toxicity. This is regarding code break 100 with patient with KRAS 12C mutation. For also this year, we have update of BOLO trial that was published 2019 in New England for patient with pancreatic cancer carry germline BRCA mutation. It's everyone familiar with this trial because it published like 3 years ago. It's phase 3, around 150 patients randomized to either olaparib PARP inhibitor or placebo, and primary endpoint PFS, and the secondary endpoint is the usual, the other objective, and it was positive trial. So, and we are familiar with this Kaplan-Meier of PFS the hazard ratio of 0.53. Now, why I present this, although it was presented 3 years ago, is the updates and the final analysis of overall survival that was published a month ago of overall survival of POLO trial. Didn't show any benefits in overall survival. For that, we didn't adapt this trial in my institution, so we are not giving patients olaparib if they are carrying a BRCA mutation as a maintenance, as the only response was a BFS. And you can see the median OS was 19 compared to 19.1 with the not significant p-value. And by the way, there was no any new safety signals or toxicity that need to be worried with this final analysis and final data of POLO trial. Lastly, I will present the last trial in the pancreatic cancer with a specific mutation or specific condition is notable a double-blinded phase 3 trial that was in China for those patients with KRAS wild type in pancreatic cancer. We all know that the KRAS wild types carry around 10 to 15% among patients with the pancreatic cancer. Most of them, they have a mutation around 80%. However, for those patients with 10 to 15%, we have this option to them, which is nimotuzumab, followed by gemcitabine. This is the experimental arm, the control arm, placebo gemcitabine. And this was anti-progression or unacceptable toxicity. The primary endpoint was overall survival, and the secondary endpoint was the usual item that we are looking for. And that was conducted in China only. And regarding nimotuzumab, it's EGFR targeted monoclonal antibody. We know that we have erlotinib in 2005. This is another medication, just only marketed in China in 2008 and can be used only in China as approved and authority there for nasopharyngeal cancer. And there is a few data here and there regarding the activity of this anti-EGFR and head and neck, cervical, esophageal, as well as other cancer. So the median OS for patient with experimental arm nimotuzumab and gemcitabine was 10 months compared to 8 months. If we look to the 1-year survival was almost doubling to some extent in the experimental arm, around 40% compared to 20%. And there is subgroup analysis for those patients with biliary obstruction need for surgery or they don't need, as well as for surgical if they have surgical history, and there was a significant difference. If you can see for those patients in the experimental arm that they do not have surgical history, they have 15 months survival compared to 6 months for those patients with the placebo and placebo arm. The BFS was also favoring the experimental arm, and there was no, again, significant toxicity on this medication. And that was in one of the abstracts this year in June, and I mean in the ASCO. So I will summarize my presentation in this algorithm. We will not go to the right side of patient with pancreatic cancer. We are all familiar with it as the option of the therapy. If you go to the left side, we have now many options. PARP inhibitor for those patients with BRCA, if you are appreciating the BFS, as we said, OS was negative. For those patients with MSI high, we can use immunotherapy. However, we are talking about 1% of patients with pancreatic cancer have MSI deficient. And for those patients with KRAS G12C, we have another option nowadays. It was approved in non-small cell lung cancer, not approved yet for pancreatic cancer, but let's wait and see. And for those patients with BRAF mutation also, we can give them BRAF inhibitor as well as MYC. However, there are only 3% of patients with the BRAF that can be that carry this mutation, and then among other of pancreatic cancer. So I just want to slide about this month that there is an active trial in Australia for with Accent phase 2 trial with focal kinase inhibitor, this medication IMB945. And the rule of this is this medication is allowing the chemotherapy to enter the cancer cell, the gemcitabine and nab-paclitaxel, allowing and facilitate the chemotherapy will go inside the cancer cell, and to have hoping that there will be improved on the BFS and OS. So nowadays we can say that precision medicine is in pancreatic cancer, and always it's better to come late than never. Unfortunately, the pancreatic cancer is one of the cancer side that we do not have that much mutation and alteration or a specific condition. However, nowadays we have like around 4 or 5 of the mutation, and we never know what will the future carry, inshallah, hope to our patients, especially in ESMO after a few weeks. Thank you.
Thank you, Dr. Fahad. We're going to question at the end, inshallah. Thank you for sticking to the time. So after pancreatic cancer, we have another session. So for neuroendocrine tumor, usually we have good players, the well differentiated, and we have the bad player, the carcinomas, and always a question about the intermediate and high grade, how to treat them. For that, we have Dr. Mirvat Mahrous, our consultant from Askari, King Sultan, Prince Sultan hospitals, to educate us about the systemic treatment in intermediate and high grade neuroendocrine tumors. Dr. Mirvat Mahrous is well-known consultant with good lectures in GI in general and neuroendocrine tumor. The floor is yours, Dr. Mervet, for the next 20 minutes.
Thank you very much, Dr. Abdurrahim, for introducing me. I would like to thank Dr. Ashwaq and Dr. Kanayan for inviting me. And it's always my pleasure to be with you in any events. My task actually is a very interesting one. They gave me the task for the neuroendocrine tumor. And so I will speak about the systemic therapy of intermediate and high-grade neuroendocrine tumor. And we know that neuroendocrine tumor is an uncommon disease. However, the classification for this disease, it's a little bit different, and it's a chronic disease different than other cancer patients. Here is my disclosure. And in the meantime, we have to know that in the neuroendocrine tumor, its even incidence is low, but is going rising, as you can see now in the graph. And in the meantime, when you look at this graph, we'll find that comparable to colon cancer or the GI tumor, this patient, they are live longer. So it's a chronic disease. And you can see even for those patients here, you can see the distant metastasis for this patient. You can see that those patients even live longer comparable to other GI tumors. In the meantime, neuroendocrine tumor, it's a very unique disease. And when you look at the paradigm for the treatment, you will find much comparable to other diseases like lung, like colorectal, and like prostate. You can see that it's a few medications here comparable to starting with 2009 with the PROMET study, and then followed by the clarinet in 2014. And you can see that reaching to 2021, we don't have much medications. And the other issue, also the biologic and the biomarkers regarding this medication. How we can identify, I will focus mainly on the intermediate and the high risk patient. However, the intermediate, it's lumped between the well-differentiated and grade 2. And you can see that as any disease, patient characteristic, comorbidities, and performance status, quality of life, and life expectancy, this is all your measures when you are looking how to treat this patient. And definitely that there is also the availability of the drugs and the safety profile and the potential toxicity. When we look at this, this is one patient since 2018. You can see that this patient has multiple lesions in the liver. Patient, he came to the clinic walking, very good performance status, and even after a year, patient looks the same, and even can see some improvements. But the main point, again, gives us a hint that this disease, most of the patients, they presented with good performance status. Even we can see that most of them, they have plenty of tumor burden. One of the surveys which is done on 2016, they asked about 1,000 patients with neuroendocrine tumor, what is your main element regarding the neuroendocrine tumor disease, what your expectations? And the first one ranking on the survey, it was the wider range of neuroendocrine treatment options, which is true. Because on reality, we don't have much options regarding neuroendocrine tumor. And the second one, you can see that the better access to the medication. And this survey, it was done by patients and for European, and you can see that it was published in 2016. And one of the main elements also for them, there is also, they were in favor to be included in the clinical trials because they know down the road, maybe they will have disease progression. So regarding the sites, again, neuroendocrine tumor, it's a different disease. So even the site, it's different regarding the treatments. For lung patient, usually we didn't start with Sandistatine LR treatments, we give them chemotherapy. So and the commonest site for the as a primary site is the lung, pancreas, and the small intestine. And why primary site matters when used to, because we used to lump it together. However, we know that when we have a different site, we have a different disease, and we have to be treated different. This is Also, a confusing part that neuroendocrine tumor is not, we don't have one guidelines for them. The commonest and the most updated one is the ENET, followed by the ESMO and also the NC guidelines and the NNET as well. One of the why we are treating different, because again, neuroendocrine tumor, we have the WHO classification for them, and you can see that those patients, we are looking at different elements, the disease site and also the differentiation. So well differentiated, even grade 2 and grade 3, and we have large cell and small cell, and this is poorly differentiated, and they are treated like a small cell. We're treated with a small with the chemotherapy, very aggressive type, and not only the differentiation, we look also on the mitosis. And you can see that for grade 2, it's less than 2. From grade 2 to grade 3, you can see from 2 to 20 and more than 20. And as you are expecting, the Ki67 going well with the mitosis. For the patient with grade 1, you can see that less than 3% comparable to grade 3, which is more than 20%. The grade of malignancy, low, intermediate, and high. You can see here the difference between them from the pathological part under the microscope, and you can see that for the grade 1 comparable to the heavily occupied cells like this, a poorly differentiated one. Another element regarding, excuse me, the functional and non-functional, most of the cases we are seeing is non-functioning, and you can see that asymptomatic. But however, for the functional patients, they have different treatment options, and this patient, they presented with severe manifestations. We look here at the TNM, and you can see that it's not applicable for the disease because it depending on the size and lymph nodes, but this is not applicable. So most of the oncologists, they are not using it. We are using mainly the WHO classification and the NET guidelines regarding this. The Sandistatine receptors, it was a huge discovery regarding this disease because 80% of NET overexpressing SSRT, and it's not only from the point of treatment, it's also from the point of diagnostic. The discovery of the Sandistatine receptors give us the octreoscan and also the gallium dotate, which is more specific, more than the octreoscan. You can see here clearly this one of the patients, this one of the patient with octreoscan here on the right side, and on the left side you can see the gallium dotate, which is showed more disease burden, and it's more specific, more than and more sensitive as well. The other element is that the blood tests, and we are relying on the chromogranin, NSE, and the pancreatic polypeptide. As I pointed out, for the imaging, we do have the CT and MRI, and we know that the CT and MRI, it's more for the grade 3 and poorly differentiated. However, for the gallium dotate, it's mainly for the grade 1 and grade 2, and it's more specific. You can see clearly here, for a patient with well-differentiated MRI and gallium dotate, it's positive. However, for patient with poorly differentiated or grade 3 disease, we have a positive disease here with MRI, and which is negative by the gallium dotate. And this explains that for the grade 1 to grade 2, you can use the gallium dotate. However, sorry. In grade 3, you can use the PET gallium, the PET scan. How we treat this patient? We are treating them with surgery, local regional, and again, we don't have much treatment, but of course the PRT, and we will have a great talk with our colleague. He will explain mainly regarding the PRT for the neuroendocrine tumor, and we are eager to hear this presentation. And the following one is a systemic chemotherapy. Are we able to go for watch and wait? Yes, for patient with low tumor burden, comorbidities, and patient here. So it can be with cautious, but it's not for all the patients, but it is adapted. How we treat this patient? Resection. always surgery is a favorable part if it's applicable, or even debulking. Here was one of my patients had partial resection, here hepatic, and he has pancreatic lesion as well. And here you can see that this patient, he was pegged with multiple lesions, and he was resectable. So definitely surgery is one of the main items regarding how to treat this patient. And the second element can be ablation, embolization. And we can see here the triad, the surgery, the systemic treatment for those patients. And we usually start for grade 2, we start for them lanreotide or epidemiology. And for patients who progressed or refractory, we can go for systemic chemotherapy and PRT as well. This is how to, again, this is give you a hint how is the treatment when we started from 80s reaching to 20s. And you can see that not much comparable. And even for the immune therapy, it doesn't show much improvement regarding, and it's all under trials, and no clinical trials from them reaching to applicable. And the dismal response rate and the dismal PFS for this patient, it was the main reason. And even here, we can see that temozolomide, capecitabine on the this part, and I will give you after in a second the last update from ASCO regarding this combination. However, this is all for the patient who progressed on the treatment, and for also sunitinib and bevacizumab everolimus in this group. You can see that the ENET looking at this group of patients, and they stratify the patient based on the grade and the mid-gut and the location as well. And you can see that the octreotide, lanreotide, for the octreotide, it's for grade 1 for low tumor burden. For lanreotide, you can go for grade 1 and grade 2 here reaching to 10%. And you can see that the mid-gut pancreas, it's mainly for those patients you can go for lanreotide. Interferon and STS, we are not using it. And you can see also temozolomide, the capecitabine here for pancreas for grade 2, and the everolimus, you can see that the grade 1, grade 2, plus or minus, and also for the lung. And of course, the PRT here or grade 1 and grade 2 mid-gut and extended disease, and cisplatin etoposide mainly for the patient with grade 3, and those patient has very high K67, and those patients, they are progressive, and they have a very aggressive disease. Most of these patients, the overall survival for them from 4 to 6 months, and unfortunately, even with first-line and second-line chemotherapy. So the first study, which showed benefit regarding neuroendocrine, and it was ahead at the time, it was in PRMID study, and it was 2009. And you can see that the study met the primary endpoint, and it was a clear separation between octreotide versus placebo with hazard ratio of 0.34, and it was 80 patients. And since this time, the Sandistatine LR showed a great benefit for this patient. And the second study down the road, it was 2014, and it was by the German group, and the study included around 200 patients, and it was about 14 countries. And you can see that the lanreotide, it was 120 milligram subcutaneous comparable to placebo, and the study met the primary endpoint as well regarding the PFS, and it was 18 versus 27 months on the lanreotide arm. And when you look at the subgroup, you can see that the study included grade 1 and grade 2. However, in the PROMIT study, as you remember, it was only included mid-gut patient, and it was included only grade 1. But in the lanreotide study, they included patient with grade 2. Even it was not a big population, but it was about 61 patients, and the majority was well differentiated grade 1, but they included the mid-gut, pancreatic, and other sites as well. And most of the study, they included patients with hepatic involvement, and it was more than 25%. When we compare the two studies, which is not recommended, but when we look at both of them, we can see that the lanreotide include more patients, and the main issue that included patients with grade 2 and with high Ki67, and this give a hint that you may use it for the intermediate grade, not only in the grade 1. So how we treat patients, we are treating them based on the morphology, based on the Ki67, and also functional or non-functional, and slowly growing or aggressive, and the disease extent, and if the patient applicable for surgery or not. This is all element when we are look at this patient. And when we look at the ESMO guidelines, you can see that it's almost similarly what we have regarding the ENET. And here we can have the watch and wait, and also we can have Sandistatine as a starting. And when we look at the grade 2, you can see that it's still applicable for them, the chemotherapy. And also they are in favor here for those patients to go for everolimus, PRT, or FOLFOX for this patient, depending on if the Ki67 more than 10 to 15%. This study, it was presented in last ASCO, and it was mainly asking the question regarding temozolomide and capecitabine in patients with advanced pancreatic neuroendocrine tumor, and they are asking, it is temozolomide plus capecitabine versus tem alone. It can be which one is better. And I have to point it out, this study, it was presented before in ASCO 2018, and they presented again for the final analysis, and we can see that the combination is in favor for the patient regarding the PFS comparable to tem alone, which is expected. However, the toxicity was higher with the combination. But we have to know that we don't, this is for the patient who progressed on Sandistatine, and the study was small one, and they are recommending the combination more than going for the single agent for this patient. As you can see here, the NC guidelines, the preferred regimen for grade 1 and grade 2 for the patient was everolimus, octreotide, or sunitinib, and temozolomide capecitabine. It was included as well, and the PRT. So the main point that they are still in favor for this treatment is specifically after a sequence of octreotide or octreotide plus everolimus, and then you can go for temozolomide capecitabine on this patient as a recommendation. And it was a mirror image to what we have in ESMO as well. Another study which is also presented in last ASCO, it was for the second line Biliary, which is liposomal irinotecan. We know this medication for patient with pancreatic cancer, and for second line therapy or third line. And for this patient, they are giving them as a second line as well. However, the study was stopped because of the fertility and because of the toxicity, but they have some response regarding this patient, and you can see that the patient has some response, but the toxicity profile was a little bit high, and they didn't recommend it much for a neuroendocrine tumor. The main point that for this patient, what to do, again, cisplatin etoposide or chemotherapy, this is the recommendations for such patient. Still, regarding immune therapy, as I pointed out before, we don't have much data, even except for a patient with MSI or TMB, but we didn't do it much for the neuroendocrine tumor. And when we look at the second line therapy, you can see that the response rate for this patient is very dismal. And you can see even for the study, it was 10%, and the highest it was for FOLFIRI or 20, or for FOLFIRI plus minus BEV. It's not chemo responsive treatment, and they are looking for the doublet regarding the dual blockade, and they may look at the possibilities for this treatment. So as a summary of the study, they are found that it can be a signal for treatments, but we have to know that about 35% of the population, they have a grade 3 adverse event, and one patient died from the therapy, and so it's not much recommended. But the authors recommending that the NET needs to have biomarkers and needs to have NGS as well, and PRF mutation, and all the patients that they need to have, because we are, even for the rarity of the disease, we need much data. One of the studies which have a lot of potential, it's a composite study. It's a usage of PRT in grade 2 and grade 3, and plus Sandistatine SSRT treatment. We are eager to see this study, how it's going. So this is my final slides regarding that, how we're treating NET patients. We're treating with a multidisciplinary team, and we have to stratify the patient based on the well-differentiated grade 1, grade 2, grade 3. For the patient with grade 2, we usually start with Sandistatine SR treatment. And for the grade 2, the preferred regimen is the Radionuclide, because it was included in the Clarence study. And in the meantime, of course, the chemotherapy as a second line, we don't have much data regarding, and also we need more medications. The genomic profile and the immunotherapy is very favorable, but we don't have data for them, but can be a step on the road regarding how to personalize therapy and how to treat them well. There is a diversity on this population, especially for the patient with secretory type, and we need to assess the patient carefully before giving them any treatment. Thank you very much for your attention.
Thank you, Dr. Mirfat, for elegant presentation and update about neuroendocrine tumors. We'll keep the questions at the end of session. We cannot sing about neuroendocrine tumors without talking about the PRRT therapy. And the third presentation was by Dr. Miad Swailmi. She will talk about, she's a consultant medical molecular and nuclear imaging in King Abdulaziz Medical City, National Guard. She will talk about the nuclear medicine treatment in patients with NET. Please, Dr. Miad.
Assalamu alaikum. Thank you, Doctor, for this nice introduction. So I would like to start my presentation with this interesting case. Here we have a case of 25 years old male with metastatic well-differentiated neuroendocrine tumor. He was progressing, unfortunately, on SSAs. So the team decided to go ahead and treat him with lutetium-177.8. So this is his post-therapy scan after two cycles of lutetium. And as you can see, there is an interval improvement of the previously seen metastatic lesions. And this is his end of treatment scan, which showed interval resolution of all of the metastatic lesions that we saw on the previous images. So welcome to the era of targeted radionuclide therapy. So on today's talk, I'll give you a general overview of neuroendocrine tumor. Probably I will not spend much time because it was well explained by Dr. Mirfat, and I will talk about the current PRRT, the famous phase 3 NETR trial, our experience in National Guard, and the future of PRRT. I don't have any disclosure. So regarding the overview, what's important to us is to know if the neuroendocrine tumor is well differentiated or poorly differentiated, because it will tell us what kind of tracer that we need to use in staging these patients, and also if they're gonna benefit from radionuclide therapy. As you all know, most of well-differentiated neuroendocrine tumor do express somatostatin receptor. So as per the NCCN guidelines, the first treatment that should be started with is the somatostatin analog. Unfortunately, most of these patients do progress on this treatment. So we need to have another options of treatment, such as chemotherapy, TKI, bilateral radiation, especially with patients with bone metastases, and also radionuclide therapy. So recently, the NCCN guidelines do recommend using lutetium-177.88 as the treatment of patients with positive somatostatin receptors and who are progressing on octreotide treatment. So what does PRRT stands for? P stands for peptide. The first R stands for receptor. The second R, radionuclide, and T stands for therapy. So as I told you before, that most of the well-differentiated neuroendocrine tumor do overexpress somatostatin receptor, and we have 5 subtypes of these receptors. So receptor subtype 2 and subtype 5 are the most receptors that overexpressed in well-differentiated neuroendocrine tumor. So by knowing this piece of information, we can target these receptors with the radionuclide therapy. So in nuclear medicine, we are dealing with unstable radioactive material. What do we mean by unstable? These materials tend to decay with time, and we have 2 types of decay. We have particulate decay and we have isometric transmission. So the particulate decay, the results of the decay, we have small particles, either alpha and or beta particles. So these particles are used mainly in treatment. We cannot image these patients if we are giving them just alpha or pure beta emitter. However, if we're gonna give the patient a gamma emitter, we can definitely image these patients. Keep in mind that we have tracers that have dual emission, which means that we can treat and also we can image the patient at the same time. So the result of the particulate emission in radiobiology is it will lead to DNA destruction. So it has a tumoricidal effect. So with the beta particle, it will lead to single strand DNA damage. However, with the alpha particle, we will have double strand DNA damage. So let's talk about the journey of the lutetium-177.88. So let's dissect this molecule. So it formed from 3 components. So first we have the radioactive component, which is lutetium. Then we have the chelating agent, which is the DOTA. So the role of the chelating agent, it will act as a stabilizer. It will stabilize this molecule in vivo. And also we have the peptide component, which will attach to the somatostatin receptor. The interesting thing about the peptide is we can play with it. So it depends what type of receptor you want to target. So if you want to target subtype 2, you will use TATE. If you're gonna target subtype 5, you will use the NOC. So the final component that we have is lutetium-177. DOTA is the chelating agent and TATE is the peptide agent. So the journey of the receptor itself, when we give it to the patient, first the lutetium will attach to the somatostatin receptor subtype 2, then it will be internalized by the lysosome. Then the beta particles will be emitted. So the result of the beta emission, it will lead to DNA damage. And as I told you before, some of the agents that we use in nuclear medicine do have dual emission. So with lutetium, there is also gamma emission, which means that we can also image the patients at the same time. This is the concept of theranostics. So we can treat what we are seeing and also we see what we are treating. So the patient's journey, first we need to confirm the status of the somatostatin receptor. So the patient need to have imaging, molecular imaging in our department, either with the SPECT tracers such as indium-111 octreotide, or we can go with the gallium-68.88, which is more sensitive and specific compared to the SPECT tracers. So then if we see like a dotatate or octreotide avid lesions, we have some sort of scoring system that we are using in nuclear medicine called Krenning score. So we compare the intensity of these lesions with the intensity of the liver and spleen. So if the score is 3 or higher, it means that this patient will benefit from radionuclide therapy. Okay, so who is eligible for lutetium dotatate? So first, definitely the patients with the somatostatin receptor positive tumor expression, well differentiated, either grade 1 or grade 2, and these patients need to be progressed either either clinically or on conventional imaging. Who are not eligible for lutetium, patients with extensive metastatic disease, especially to the liver and bone, and patients with limited bone marrow, renal, or hepatic reserve, and definitely patients with poor performance status. Okay, so how we perform this treatment. So the first thing you need to know that most of the tracer that we are using in nuclear medicine get excreted through the kidney. So it means that lutetium might have an nephrotoxicity. So how we can prevent that? By infusing amino acid. So we use two types of amino acid. We have the lysine and the arginine. So first, the patients needs to have two IV line, one for the amino acid infusion, and the other line is for the lutetium infusion. The downside of infusing amino acid is some of the patients will experience some nausea and vomiting. So we need to prevent that by giving the patients antiemetic prior to the infusion of the amino acid. The amino acid infusion will continue for 4 to 3 hours. However, the lutetium infusion lasts around 30 to 40 minutes. Okay, how we sequence this therapy? First, we need to stop any SSAs, medications, either short-acting or long-acting. It depends on the time. Long-acting needs to be stopped at least 4 weeks, short-acting 24 hours. The patient needs to have also recent blood work. And when we decide to give the patient the yttrium, we go with the fixed dose approach. So most of the patients will receive 200 millicurie. Then they need to have also a follow-up blood work 3 to 4 weeks after the infusion, and we repeated it for 4 weeks. As I said before, we can also image the patients. It depends on the center that you are working in. You can do the images after 24 hours, or you can do it also after 48 hours. And I forgot to tell you that you can also give the patient somatostatin analog, but it needs to be after the infusion of the lutetium. This is an important thing that we need closed loop communication with the oncologist because any side effects need to be reported as it will affect the management plan. So in terms of the post-treatment care, the patient needs to have a post-treatment laboratory test after the infusion. We need also to arrange for the monthly SSAs injection, and also we perform post-therapy scan after the infusion. So in terms of the toxicity and side effects, lutetium-177 is considered a safe drug. I will address the toxicity and the side effects when we discuss the famous NETTER trial. So in terms of the contraindication, we have absolute contraindication. So pregnancy is one of them. If the patient has severe illness and if they have uncontrollable psychiatric disorders. So regarding the relative contraindication, it is debatable, but the most thing that we need to pay attention to is renal obstruction. So it needs to be corrected prior to the administration of lutetium. If the patient has also fluid overload and hepatic failure, all of these needs to be corrected before the lutetium as it's considered as a relative contraindication. So talking about lutetium means that we need to talk about the famous NETTER trial. So the NETTER trial is a phase 3 study of lutetium-177 in mid-gut neuroendocrine tumor. So this was the first randomized phase 3 clinical trial on PRRT. So they enrolled around 231 patients with advanced somatostatin positive a disease of the mid-gut, and these patients were progressing on the standard SSAs. So these patients were randomized in 2 groups. So the first group will receive lutetium-177 dotatate with a low dose of SSAs, and the second group will receive only high dose of SSAs. So the endpoint of this study is to measure the overall survival and progression-free survival. So as you can see here from the graph, so there is a significant prolonged progression-free survival in the group who received lutetium with SSAs compared to the control group who received only the SSAs. So the estimated progression-free survival was 40 months compared to 8.4 months with the high dose SSAs. The higher results of the progression-free survival, this would lead the FDA to approve lutetium 177.8 in treating patients with well-differentiated neuroendocrine tumor. So what about the overall survival? There is no statistically significant in the lutetium arm compared to the control, but there is a reason for that because some of the patients were progressing. The patients on the control arm were progressing, so they were shifted to the lutetium arm, so they received radionuclide therapy because of the progression. And the final results was published in 2021, and the median overall survival in the control arm was 36.3 months and 40 months in the PRRT lutetium arm, and we know the reason for that. So regarding the reported events in the NETR trial, the adverse events was around 1.8% in PRRT lutetium patients who developed myelodysplastic syndrome. The good news is that no new cases of myelodysplastic syndrome or acute leukemia were reported in the long-term follow-up. Okay, so the conclusion of the NETR trial, lutetium can lead to statistically and clinically significant improvement in the progression-free survival as the primary endpoint. And the overall survival was not well demonstrated because there was a crossover between the control and the lutetium arm.
5 minutes.
So our experience in National Guard, they started to treat patients with radionuclide therapy from 2014 to 2019. We only treated 6 patients, and they used to receive a cocktail of yttrium and lutetium. The last 2 patients were treated in 2019, and it was stopped due to COVID and interruption of amino acid supplies. So the last thing I will cover it quickly is the future of PRRT. So our standard approach is we are using lutetium 177.8. We have fixed dose 200 millicurie. We give it IV, number of cycles 4, and in terms of sequencing and combination, we combine it with we use it as a second line and we combine it with the SRR indication. It's mainly in well-differentiated grade 2, grade 1 or 2 neuroendocrine tumor. So can we change it? Yes, most of these components were looked at in clinical trial, and one of the things that we can use alpha emitters instead of beta emitters, and this study by Alpha Medics, we're testing using lead instead of lutetium, and it's going on, it's phase 1 trial. The second trial by this company, Raise Bio, and they are using actinium instead of lutetium, and the same indication as well. So with those, we are using fixed dose. We can go lower if the patient has some complication. The future approach is we can personalize dose based on the patient's clinical status and imaging finding. Can we use it in maintenance therapy? Only time will tell. The numbers of cycle in US, they are limited to a maximum of 4 cycles due to insurance company. In Canada, they are trying to use it as a salvage treatment, which makes sense if the patients did benefit from the 4 cycles. Now we're using lutetium as second or third line monotherapy with the SSAs. Can we use it like a new adjuvant therapy, especially in patients with large tumor burden, to just shrink in these tumors and make it feasible for the surgeon to take it out? And can we combine it as well with chemotherapy instead of only SSAs? So conclusion, PRRT is highly effective in controlling advanced and metastatic or inoperable neuroendocrine tumor. PRRT help relieving the symptoms, improving the quality of life, and slow the progression of the disease. PRRT considered as a second-line therapy in mid-gut neuroendocrine tumor and third-line therapy in PNUT by most of relevant scientific societies. Lutetium 177.88 is recently approved by Health Canada in treating progressive, well-differentiated GAP neuroendocrine tumor. Thank you so much.
Assalamu alaikum. Thank you. That was a great session. Dr. Fahad, can you please come up? Dr. Mi'at, Dr. Mervat, and me and Dr. Walid will run the questions for the sessions. So that was a good session with taste of pancreas, neuroendocrine, molecular, and all the cool stuff that the molecular can do. So I'm going to start with Fahad. Fahad, I have a question. I have actually one question here about ours. I'm not going to give it to you, but the question that I'm going to ask you, you showed us in the trial about the neoadjuvant in borderline and the benefit for treatment chemotherapy for patients with pancreatic cancer. My question, for those with molecular, alteration like ROS, for example, EGFR and all those mutations that we can target, do we still go with chemotherapy for those patients? Do we start with the targetable therapy? I'm asking about the pancreatic borderline.
So it's a great question. If you are asking about outside the context of clinical trial, yes, this is the either borderline / resectable, you have to go with the chemotherapy then resection. For a patient with advanced, this is a totally different scenario. But outside the context of clinical trial, you cannot start targeted therapy for those patients with borderline / resectable with targeted mutation, although they have targeted mutation. So your aim is curative and not yet approved or used the targeted mutation in those kind of patients.
In the same context, Dr. Fahad, for those on palliative treatment, do you start with your chemotherapy or you start ahead with the targeted therapy for metastatic setting?
Yeah, so in metastatic setting, my practice, and I believe everyone practice, is to use the palliative chemotherapy. No targeted therapy yet can be used as a first line or upfront, unless we are talking about like MSI high and those kind of patients with 1 to 3%. Yes, it's an option here, especially for the patient with a borderline performance. However, for most of our majority of the patient, they are coming with a borderline performance status, so or like acceptable performance status. So you start with the standard FOLFIRINOX or Gemnab paclitaxel.
Thank you, Dr. Fahad. Dr. Walid?
Yes, thank you, Abdul Rahim. Just to continue with Dr. Fahad, Fahad, for patients with excellent response to the first line, let's say FOLFIRINOX or Gemnab, are you practicing to give some of those patients maintenance if he's in good shape, maintenance chemotherapy? I mean, just drop the oxali, continue maintenance, or for Gemnab, stop the Gem and continue NAB. I mean, the maintenance strategy.
Yeah, I'm using this strategy in my practice, and I will continue, as you said, 5-FU-leucovorin, omitting oxaliplatin, as you know, for the neurotoxicity. I'm not a big fan of the POLO trial as a maintenance for those patients with the BRCA mutation. As we said, it's a BFS, and we did not adapt this in my institution. So the only option is either wait and see and give the patient a better quality of life, or a maintenance. And at the end, it's a decision of the patient. However, I'm lean more for the maintenance of the FOLFIRINOX, omitting the oxaliplatin, so only 5-FU-leucovorin.
Abdul Rahim?
Dr. Mervat, question about neuroendocrine tumor. Grade 2 usually is a nightmare. Sometimes you treat based on the clinical behavior and they fail you, or you fail them, like as an oncologist. Sometimes they may be a good player. So always for me, it's a gray area for grade 2, the intermediate group. You clearly showed us nicely in your lectures the way that we treat them. My question, after progression on hormonal therapy and starting chemotherapy for those patients, do we drop hormonal therapy or we continue to give it with them?
Thank you so much, Dr. Abdurrahim. This is an excellent question because it's a reality. So we do have, as you pointed out, it depends on the patient's comorbidities and also the tumor burden. So the progression for them, is it tumor progression, radiological, and also biochemical by the chromogranin. Chromogranin just give you a hint. So the main point that we are seeing that the patient is in a definite progression, and patient he is under either Sandistatine LR or he is under lanreotide. You have two options. You can intensify because we do have a study for intensification treatment for this patient by increasing the dose or by by escalating the dose or by decreasing the period. For example, if you are starting for the patient with lanreotide 120 milligram and patient is in progression and patient is doing well and because it's a slowly growing disease. And so you can, instead of giving them monthly, give them every 2 weeks. And we do have this data, even it is a phase 2 study, but it was launched in the ENT meeting this year. And it showed that the patient who need intensification by shortening the period or increasing the dose, they have a benefit. The other option, if the patient, he is not even, if we are shortening the period every 2 weeks, patient is still need for a treatment. You still have the other study, which is Radiant study. You can go for the octreotide plus everolimus, or as a combination, you can go with the combination with afinitor. This is the options for us. If the patient progress, you can go for chemotherapy for FGFR if we do have. So depending on the situation, but as you pointed out, so your question mainly, can we drop the sandistatine? And we can, you can do this because there is a single study for everolimus or students, but we do have recent data that shortening the period for the patient or intensifying the dose, escalating, it can be for them.
Abdurrahim, if you allowed me, Abdurrahim.
Go with it.
Yeah, for Dr. Amiad, thank you for updating us regarding the PRRT therapy and your case presented. The two questions I have. First questions, when the indication of PET scan before PRRT for a patient with SSR positive disease. I mean, positive disease by the gallium scan, when to indicate to do PET scan. This first. Second, when should be stop the octreotide before gallium scan?
Okay, so let's start with the first part. So you are asking about the staging, PET, or before the lutetium therapy?
No, before lutetium therapy, yes.
Okay, so as I mentioned, we need to confirm the status of the somatostatin receptors. So most of these patients will have both gallium-68 dotatate because in well-differentiated neuroendocrine tumor, these lesions will be gallium dotatate avid lesions. However, we do both. We do study PET-CT with the gallium-68 and we do also with FDG to assess of dedifferentiation. So if we go ahead and did the PET, both PET with the FDG and the gallium, and the FDG was negative, but the gallium was positive, it means that this patient can benefit from the radionuclide therapy. So the second question is about when do we stop?
Yes.
Yeah. Yes. So it's encouraged by the American guidelines to stop the somatostatin analogs prior to the PET. But to be honest, most of centers do not stick to it because like some of these patients tend to be symptomatic. So I think it's impractical to stop like long-acting somatostatin analogs 4 weeks prior to the PET. However, it's mandatory to be stopped prior to the lutetium therapy. But in terms of PET, either with FDG or gallium, I think it's okay. We can go ahead even if the patient is on somatostatin analog and do the scans. But it needs to be stopped before the lutetium, definitely.
One more question. Let me just okay. There's a question here from the audience about what's the prognosis of PRRT if used alone as palliative therapy? And let me just do some modification to that question. We know, like in nuclear, guys, you tricked us in a good way. You started from radium. Let's just do it. Then now, PSMA scan, and now it's treating as well for lutetium-177, enroll in PRRT. My question, if we look to the PRRT for people in neuroendocrine tumor, who has pain, who has like some symptom, is there any role for palliative treatment for those patients just for the symptoms management?
On the NETTER trial, actually, they did comment not only on the progression, the overall survival and progression-free survival, they also comment on the symptoms and also quality of life. And they did see that there is improvement in terms of symptoms control and quality of life in the arms of patients who did receive both lutetium with the with low dose SSAs. So I think it's still not well studied. However, but I think these patients can benefit, but still it's under trial, especially for using it as a palliative.
Okay. Thank you guys for taking time. Thank you, Dr. Miad, Dr. Fahad, Dr. Murfad, Dr. Walid for moderating the session. I think this is the end of the session. We're going to have a few minutes for coffee and coming to the second session. Thank you, guys.
Thank you, Abdurrahim. Thank you.
Yeah. Good morning. So we'll move to session 4, which is about biliary tract cancer. So we are glad to have 2 moderators. First moderator, Dr. Ru'a Shafi. She is a consultant medical oncology in Princess Noura Cancer Center in National Guard Jeddah. And we have Dr. Mohammed Al-Ghamdi. He's a consultant and director of the Cancer Center at University Hospital in Riyadh. Ru'a, Mohammed, floor is yours.
Assalamu alaikum warahmatullahi wabarakatuh. Thank you, Dr. Ashwaq, Dr. Kanaan, for the invitation. I'm glad today to be presenting about the biliary tract cancer. You know, before in the old days, it just like lumped together with other cancer or very small talk. Now we have a whole session with 3 brilliant speakers that will go through different even approach for therapy. So starting with the NGS rule and biliary tract cancer, Dr. Saeed Turkey, who's a consultant, molecular genetics, genomics, and bioinformatics of our labs from Riyadh, Saudi Arabia. So we'll start with that, then following, we'll introduce next speaker later. So, Dr. Saeed.
Assalamu alaikum. Good morning, everyone. Thank you, Dr. Roya, for the introduction and for the kind invitation by the scientific committee, Dr. Kanaan, Dr. Ashwaq. It's my great pleasure to be here today. And while preparing for this presentation, to be honest, I was a little bit gloomy looking at the current situation with the BTC. We are not receiving a lot of NGS requests, but looking at the option today and the overall survival 5 years, it's really low. For the resectable with adjuvant chemotherapy, as you know, 7 to 16%. And for the chemotherapy in the metastatic, it's 2%. So I was hoping to look for biomarkers that could help with for those patients. And the anatomical classification is of a great importance here because it seems to be there is a clear association between some of the molecular biomarkers and the anatomical position. Looking at the cholangiocarcinoma, there is the intrahepatic, around 10%, extrahepatic, around 20 to 30, and the rest are cholangiocarcinoma. While gallbladder and biliary are important, they represent very few cases, so it will not be the part of this discussion today. The last few years was, we witnessed a huge explosion of biomarkers in the BTC. This table represents the biomarker under each anatomical location. Some of these are very high, but not very important as well for therapies. TB53 as an example here, above 30% in most of these subtypes. However, Fgfr and Idh1 is high in the intrahepatic. The other usual suspect, BRAF, EGFR, also appear in all of these types, although at a lower level. So for the rest of the discussion today, I will just focus on 2 of them, FGFR and Idh1, because they represent the highest biomolecular frequency. The FGFR is 4 family members. They are transmembrane molecules. And they are involved in downstream signalings for the RAF, BIC3CA, mTOR, and they are involved in many signalings, mitogenesis, differentiation, angiogenesis, etc. The way it's actually its works through a gain of function, and there is 3 different mechanisms for that. That is very of importance for the type of testing we go for. The first one is the protein overexpression of the transmembrane. The other one is activating mutations. The third type is fusions. And all of these increase the signaling, downstream signaling. If we zoom a little bit out and look at all cancers, FGFR represents around 7% of all solid tumors. And if we break down, you will see that FGFR1 is the most common one, around 50% of the cases. And this makes it a very interesting biomarker that could have the potential of being bank cancer like the enteric. This slide shows the list of different cancers and the frequency of those FGFR mutation and fusions. At the top is the urethral carcinoma, followed by breast and endometrial. And if we just zoom in the cholangiocarcinoma, it's in the middle, around 7%. And there is two things important here. One is the purple color, which is basically most of the mutation happen in FGFR2. And most of the mutation in FGFR2 are either amplification or fusions, and a little bit of mutation. So this means that we can use FISH for only testing FGFR2. If we move to the IDH mutation, that you will see that cholangiocarcinoma, it appears around 13% or 14%. And interestingly, we have two genes, IDH1 and 2. Almost all of the mutation in IDH1, not in 2. So this also could be a potential single gene testing for IDH1, and mostly in a very specific location, 132. If we compare it for other cancers, glioma, chondrosarcoma, you will see a mix between IDH1 and IDH2. It's not clear why IDH1 only is seen in the liver, but probably because of the biological function. IDH2 is mostly in the mitochondria, IDH1 is cytoplasm, but the clear association is not clear why this is the case in liver cancers, in the biliary tract cancers. There is a plethora of other alteration. We just discussed FGFR2 and IDH1 in the intrahepatic. But if we look at the whole spectrum, you will see KRAS is extremely high, between 30% and 45%, including the famous 12C mutation, which is very important. ERPB2 or HER2 is also very important, between 10 and 15%, and that can be detected by FISH. BRAF, 3% across all the types. And interestingly, the homologous recombination deficiency, it's between 5 and 15%, which is for the PARP inhibitor. And finally, the microsatellized high, which is can show exquisite sensitivity to immunotherapies, but it's low at 2 to 5%. So coming to knowing all of this, what does that mean for molecular testing? So if I summarize, there is 3 types of mutations. We have point mutation or insertion deletion, like IDH1, KRAS, BRAF. The second group is amplification, the HER2 is an example. And the third group is the FGFR2 fusions. If you will go with BCR, single gene testing, it's fantastic for all of these 3. It can detect all of them. The pros is turnaround time is extremely fast, 3 to 5 days, very low cost per single test. But the problem here is you will need a lot of testing. So together, this actually could increase the cost more than the NGS. And the other problem is PCR is always targeted. So you have to know what's the mutation before you test. If it is novel or unusual or rare, it will not be detected, which is a source for false negative results. FISH, on the other hand, fantastic for HER2. It seems to be the golden standard. Also for fusions, it's extremely fast, low cost, but the problem, it will miss almost all the other type of mutation. So not good for point mutation and indels. Array, great method. Unfortunately, it's only for amplification, very costly, and does not, it will miss the fusion completely. It will miss all the point mutation. So absolutely not recommended whatsoever in this scenario. NGS has the potential to detect almost all of the previous. And with the price tag that is more than the single gene testing, and a little bit of increase with turnaround time, 7 to 10 days, and it's improving nowadays. But NGS also, there is so many types of NGS, whether it's technology or methods, but also the panel size. You will see on the left 100 gene panels or lower, middle size panel 300 to 500, and the extreme on the extreme side is the 20,000 genes by exome or RNA-seq. And each comes with its tag price and also complexity in the analysis. The good thing about the smaller panel is Usually we require a little bit of DNA and RNA, so it's not hungry for tissue. That's one. Two, cost-wise, it's fantastic. Third, analysis. The smaller the panel, the less variant of unknown significance that we need to deal with. Of course, the bigger the panel, we'll see things that we don't know what to do with. It will confuse both molecular pathologists as well as the oncologists what to do with it. And this is true, very true for the 20,000 genes. It's only research. I would say the only benefit for 300 genes panel in this scenario is the immunotherapy, because it will detect MSI, it will detect tumor mutation burden. So it's a good, but you may need to make a decision since the immunotherapy will only be in 2 to 3%. So you may go for a 2 phases testing. First, the small panel. If it is negative, then you go for a larger panel. One of the most commonly used panels at least in Saudi Arabia is the Oncomayan 52 gene panel. It's FDA approved. It detects multiple genes in the guidelines. And when we zoom in the biliary tract, it detects BRAF, KRAS, IDH1, FGFR, NTRK, the usual suspect, except the MSI and the tumor mutation burden. It's not covered. And the sensitivity is great for point mutation, insertion deletions, and fusions. CMV, or the amplification, it looks from the publisher or the manufacturer is at 96%. But to be honest, I would never trust these smaller panel for amplification, especially HER2. So this is also a caveat for this smaller panel. So in summary, it's great to see a plethora of molecular biomarkers. Almost, if we look at this figure, there is 30 to 40% targetable mutation in IDH1, FGFR, HER2, BRAF, NTRK, and MSI high. The rest, there is also a plethora of biomarkers, but not yet tested in clinical trials, although some of these are very well known in the lung cancer, ROS1, ALK, and RIT. The rest, 30%, is still a gray zone with unknown pathogenic or targetable mutations. This is the final slide, choosing between NGS and PCR. I think if cost is no issue, go for the NGS smaller panel. But if it is, then the anatomical position of the tumor may guide you through a single gene testing, whether PCR or FISH. But its NGS is getting cheaper by the day, and it seems to be the gold standard in the next few years. Thank you very much.
Thank you so much, Dr. Turki, for the excellent review. So now, after hearing about all the molecular target, let's go and hear from Dr. Samah Al-Rahili about clinical implications of all of these targets. Samah is a medical oncologist at King Abdulaziz Medical City in Jeddah, who is specialized in GI and lung cancers. Samah.
Assalamu alaikum. Good morning, everyone. Thank you, Dr. Mohammed, for the introduction. I would like to thank also Dr. Ashwaq Al-Aliyan and Dr. Kanaan Al-Shammari for the invitation. I was asked today to talk about targeted therapy in biliary tract cancer. So in cholangiocarcinoma is a highly heterogeneous tumor. And we actually subtype the disease depending on the anatomical site, either intrahepatic, perihilar, or distal. It's a very bad disease with a very poor prognosis. 5-year overall survival is less than 20%. There is an increase in the incidence of the disease globally. And to understand why the incidence is increasing, we need to understand the epidemiology and risk factors. And this is a paper by Dr. Clement and his group, where they actually did a population-based study, and they have identified different risk factors. And they actually also noted that there is a rising global incidence of cholangiocarcinoma may be linked to increase in obesity, type 2 diabetes, and non-alcoholic liver disease. And also the risk factors for the intrahepatic cholangiocarcinoma is different than the risk factors for the extrahepatic cholangiocarcinoma. Then there is this paper from the European registry. Metabolic-associated conditions are altering the epidemiological setting of cholangiocarcinoma, and the non-alcoholic fatty liver disease, and in particular NASH, increase the risk of cholangiocarcinoma. In this slide, you can see treatment options. In 2009-2010, we had cisplatin gemcitabine as one of the standard first-line treatment options based on the ABC02. And then in 2018, based on the ABC06, FOLFOX became one of the options in the standard of care as a second line. And then, as you can see in the later years, the slide is getting busy, and we have more treatment getting approved or in ongoing trials. Hopefully, with the next few years, we'll have more and more options for this deadly disease. When we talk about chemotherapy, so ABC02, comparing gemcitabine single agent versus gemcitabine and cisplatin, and there was a survival benefit, 11.7 for the combination versus 8.3. And then for the FOLFOX, there was comparing FOLFOX compared to symptom support, and there was a median overall survival 6.8 versus 5.3, and the 12-month survival rate is 25 versus 11. When we look at what we have as a chemotherapy options in the first-line setting, we have cisgem and cisgem durvalumab. Dr. Shammari will talk about immunotherapy. And then in the second line, we have FOLFOX, we have liposomal irinotecan and S1. And the overall response rate is in a single digit for the second line, except for the liposomal irinotecan and 5-fluorouracil. Switching gears to targeted therapy. So precision medicine is not for everyone, and maybe we can say this in biliary tract disease. Reason number one is quality tissue sample not always available. So it's either it's an extrahepatic disease where all what we have is a brush and cytology, and it is not enough for testing, or it's an intrahepatic disease. They did biopsy and they found that 26% failed testing, and the reason is insufficient tumor content. The other thing is there is a 40% of the patient, they have a targetable mutation, but still we have 60%, they are not suitable for targeted therapies. And maybe there will be more discovery, so we'll have more percentage of targetable diseases. Then when we look at the molecular genetics, it is different from intrahepatic to extrahepatic to gallbladder disease. Fgfr2, TP53, IDH1 and 2 is more common in the intrahepatic. In the extrahepatic, KRAS and TP53 and SMAD4, and then in the gallbladder, TP53 and HER2 amplification. I'm going to cover in my presentation these targeted medication and the study behind approval. So IDH1 accounts for 15 to 20% of intrahepatic cholangiocarcinoma. It does not have a prognostic value as in gliomas. And this is one of the early trials for IDH1 mutation, testing ivosidenib, where actually a median PFS was 3.8 and median overall survival was 13.8. Then this led to more trials, and we have the Clardy study, which is a phase 3 trial. Their eligibility criteria, histologically confirmed diagnosis of cholangiocarcinoma, confirmed by NGS, excellent performance status, and they have 1 or 2 prior therapies, at least gemcitabine or 5-fluorouracil containing regimen, and then they randomized patient double-blinded randomization 2-to-1. Ivosidenib versus placebo, crossover permitted, and the primary endpoint was PFS. So 70% crossed over to open label ivosidenib upon radiologic progression, and 15%, including 6 patients who crossed over placebo, remained on the medication for a year or longer. When we look at the primary endpoint, PFS, the median PFS is 2.7 for ivosidenib versus 1.4, with a hazard ratio of 0.37, and disease control rate is 53% in ivosidenib versus 28% in placebo. Important to highlight, only 2% they had a partial response, majority they had actually stable disease. Then given the crossover, the median overall survival is 10.3 versus 7.5. And for the crossover, what they did is they did the rank preserving structural failure time model, trying to actually clear or clean the cloudness that happened from the crossover. And the median OS for placebo after adjustment for crossover was 5.1 months. Hazard ratio for the intention to treat is 0.79. After the adjustment is 0.49. August 2021, FDA approved ivosidenib as the first and only targeted therapy approved for patients with previously treated IDH-mutated cholangiocarcinoma. Then FGFR2 fusion seen in approximately 10 to 15% in the intrahepatic cholangiocarcinoma. There is a study suggesting that it has a prognostic factor, and if patient who has the mutation actually did better than the patient with no mutation. Then one of the medication is Amphigratin. It was tested in an open label phase 2 study design for patients with unresectable locally advanced or metastatic cholangiocarcinoma. And the primary endpoint was objective response rate and duration of response. Objective response rate was 23%. They had 108 patients. And then when they looked at the objective response rate for the patient who just received one line of therapy, which is around 46% of the patient, the objective response rate was 34. So this is important point because it will question what will be the best sequencing of these medications. Then disease control rate was 88 versus 81, and median progression-free survival is 7.3 versus 7.4. As you can see here in the water plot, majority of the patient has a partial response or stable disease, and a few patients had a progressive disease. And based on this, as FDA approved the medication and accelerated approval of the Amphigratin for patient with FGFR2 fusion positive advanced cholangiocarcinoma. Because it's an accelerated approval, they need a confirmatory study. Approved is an ongoing study. And in fact, they are testing Amphigratin in the first line setting. So they randomize patient to Amphigratin versus chemotherapy, the standard of care CES-GEM. And they did allow a patient to receive one cycle of chemotherapy while awaiting for the testing. And their primary endpoint is PFS, and it's still ongoing. Then based on the FIGHT 202, we have the approval for bemigatinib. In bemigatinib, majority of the patients received the drug after first-line therapy. Overall response rate is 35.5%. Median progression-free survival is 6.9 months. In April 2020, FDA approval of pemigatinib for patients with FGFR2 fusion-positive advanced cholangiocarcinoma. Then from recent ASCO, we heard about the Phoenix trial, which is a phase 2 global study testing fotibatinib in the FGFR2 fusion or rearrangement in the intrahepatic cholangiocarcinoma. So the key eligibility criteria is unresectable or metastatic intrahepatic cholangiocarcinoma with the fusion or rearrangement and prior GEM platinum chemotherapy and progression after at least one systemic therapy with excellent performance status and no prior FGFR inhibitor. Their primary endpoint is objective response rate, and the objective response rate is 41%, disease control rate is 82%, median PFS is 8.9, and median OS is 20 months, which is impressive. they submitted for FDA to get an approval, and we're still waiting for the approval. So for IDH, we have ivosidenib. For FGFR2, we have 2 approved medication, Amphigratin and Pemigatinib, and hopefully soon we'll have futibatinib as an option in the FGFR2. Moving to HER2. So HER2 in ASCO, GI ASCO 2021, they presented data about zanidatamab, and in the zanidatamab, actually the objective response was 40%. It was a small number of patients, 20, and the disease control rate was 65. Median duration of response was 7.4. And then in Lancet, they published the MyPath study for the combination pertuzumab, trastuzumab in the HER2-positive metastatic biliary tract. It was a multi-center open-label phase 2A multi-basket study. And in this study, the objective response rate was 23%, disease control rate was 51%, duration of response was 10 months, and PFS was 4, overall survival is 10.9. Then trastuzumab deruxtecan from recent ASCO. Trastuzumab deruxtecan is an antibody drug conjugate composed of humanized monoclonal anti-HER2 antibody, a cleavable tetrapeptide-based linker, and a potent topoisomerase 1 inhibitor. There was a survival benefit of the drug in breast and gastric, and in ASCO they presented the HERB trial, where actually they included patients with HER2 positive and low HER2 low expressing. Histology confirmed unresectable or recurrent BTC, confirmed HER2 expressing, refractory or intolerant to treatment, including GEM. And it was a multi-center single-arm phase 2 trial. So for the PTC, they were screened, and then the HER2 positive defined as an IHC +3 or IHC +2 and ISH plus, or HER2 low expressing defined as if IHC or ISH, either of one of them is +1 positive, or both +1 positive, or IHC is +2. And they included or recruited patients from 2019 till 2020, 300 patients screened, 296, they had the IHC and ISH result, 61 had HER2 positive, and 120 HER2 low expressing tumors. Confirmed objective response rate is 36% in the HER2 positive, 12.5% in the HER2 low expressing. Confirmed disease control rate is 81 versus 75. And then secondary endpoint PFS in the HER2 positive is 5.1 months, and HER2 in the low expressing is 3.5. When we look at the OS in the HER2 positive is 7.1, and in the HER2 low expressing is 8.9. When we look at the toxicity profile, it was the profile was quite similar to what we learned from previous trials. Important to highlight that pneumonitis was around any grade 25%, and grade 3 or more around 12.5%. BRAF specific mutation in the BRAF gene, BRAF V600E, it accounts of around 5%, especially in the intrahepatic cholangiocarcinoma. A ROAR study where they combined dabrafenib, trametinib for BRAF V600E. Overall response rate is 47%. Median PFS is 9 months. Most of these patients were actually previously heavily pre-treated patients with more lines of prior therapies. In June 2022, FDA approval of dabrafenib, trametinib in the BRAF V600E mutated unresectable or metastatic solid tumors. So in conclusion, clearly there is a rule for profiling all patients of PTC patients. Tissue can be an issue, and we have clear options for FGFR2, IDH1, HER2, BRAF, and more are coming. Drug accessing medication can be a challenge, and some medication, the benefit is marginal, with the cost is very expensive, so we need to think about this. And also sequencing of medication will be a question in future. And by this, I conclude my presentation. Thank you.
Thank you, Samah, for the elegant presentation. We'll leave the question at the end. I'm honored to present the next speaker, my dear colleague, Dr. Kanaan Al-Shammari, who is a MENA's NCCN Center Director and also Medical Oncology Consultant in King Abdulaziz Medical City in Riyadh. Kanaan, microphone is yours.
Thank you, Dr. Ra. So I was given a task to talk about immunotherapy in biliary tract cancers. So my talk is going to complement what Dr. Saeed Al-Turki spoke about and what Dr. Samah Al-Haili spoke about. So I'm going to talk in general about biliary tract cancers. I'll talk very briefly about biomarker-based therapies. Then I will present several phase 2 studies that actually investigated single-agent immune checkpoint inhibitors in biliary tract cancers. Then I'll spend some time talking about TOPAZ-1, and I'll end up by talking about upcoming studies. So biliary tract cancers still remain quite rare. The incidence of intrahepatic cholangio is increasing. Prognosis is unfortunately still poor, with 5-year overall survival of less than 20%. This is mainly because more than 70% of cases actually present late, and relapse rates are quite high in resected biliary tract cancers. The basis of therapy in the first line setting has always been chemotherapy, probably for the last decade or so, with gemcitabine and cisplatin being standard of care up until probably a few months ago. The median overall survival remains under 1 year, and this suggests a huge area of clinical unmet need. Immunotherapy and other therapeutics are being considered in many different cancers. We have 2 FDA-labeled indications for pembrolizumab for tumor-agnostic FDA indications. One is for high MSI, and the other one is for tumor mutational burden of more than 10. Now I'll present the percentage of those in biliary tract cancers. PD-1 inhibitors unfortunately show modest activity as monotherapies, and there are several phase 3 trials that actually investigate immune checkpoint inhibitors in combination with chemotherapeutic agents. So probably the basis or the standard of care has been based on the ABC02 trial, which investigated cisgem or gemcis in a UK study that was an open label phase 3. And this basically randomized patients to gemcis versus gemcitabine alone. Overall survival was less than a year, so it was 11.7 months, and progression-free survival was around 8 months. Response rates were actually decent at 26%. And there was, of course, more neuropathy expectedly in the cisgem group. In terms of subsequent line therapy, I know Dr. Samah briefly touched upon this. We have FOLFOX based on the ABC06 trial, and we have nanoliposomal irinotecan with 5-fluorouracil. Both of them give you an extended overall survival, which is modest in the second line setting and beyond, of 6 to 8 months. There are some targeted approaches for biliary tract cancers. Now, I'm not going to spend some time on this. However, I want you to pay attention to the first 2. So when we look at the frequency in cholangiocarcinoma of MSI high disease, it's around 3%. And pembrolizumab as a single agent gives us an objective response rate of 40%. And this is a tumor-agnostic FDA approval. For TMB of more than 10 mutations per megabase, the frequency actually ranges between 2 to 5%. And with pembrolizumab, we have an objective response rate of around 30%. Now, in terms of older single agent immune checkpoint inhibitor studies. We have nivolumab, which has been studied in a phase 2 trial. Objective response rate, unfortunately, is quite modest at 11%. However, when we look at the PFS and overall survival, it is actually, it does provide us with a higher, numerical higher overall survival and progression-free survival if the tumor is PD-L1 positive. Pembrolizumab as a single agent was investigated in 2 prior studies, Keynote 158 and Keynote 028. In terms of objective response rate, also as a single agent immune checkpoint inhibitor, very modest, and it ranges between 5% to 13% only. Now, this is probably the basis of TOPAZ-1, and this was based on a phase 2 study that was presented 2 years ago in ASCO, and it investigated the addition of durva plus minus tremelimumab on top of gemcitabine and cisplatin. Now, remarkably, this actually had a very high objective response rate of more than 70%. So TOPAZ-1, which was presented in the most recent ASCO, is a phase 3 randomized, double-blinded, placebo-controlled study of the addition of durvalumab in combination with cisgem in patients with advanced biliary tract cancers. So it is the first global phase 3 study that actually evaluated the addition of an immune checkpoint inhibitor with chemotherapy that was presented in a big international meeting as a first-line therapy for advanced biliary tract cancers. So in terms of the study design, there was randomization 1-to-1. The number of patients that were treated were a bit higher than 600 patients. They took all metastatic biliary tract cancers. These include intrahepatic and extrahepatic cholangiocarcinomas, plus gallbladder adenocarcinoma. They added 1,500 milligrams of durvalumab every 3 weeks on top of cisgem, and they maintained durvalumab after finishing up to 8 cycles of cisgem, versus cisgem up to 8 cycles, and then continuation of placebo until progression. The primary endpoint was actually overall survival. Now, the statistical design, the study was actually powered to test the difference between overall survival. And if the overall survival was statistically significant, the statistical methods reported that there will be an additional testing of progression-free survival, which was the case in this study. Now, when we look at patient disposition, when we look at ongoing treatment at data cutoff, almost 20% of patients with durvalumab were still on therapy, compared to only 5% of the gemcis plus placebo. Let me move on to the next slide. So in terms of baseline characteristics, they were almost identical between the 2 groups. Now, this was a rather fit group with ECOG performance status of 0, being in 50% of enrolled patients. Most patients actually had cholangiocarcinoma at probably more than 70%, including intrahepatic and extrahepatic cholangios, with around 25% having gallbladder carcinoma. Now, most patients, more than 80%, were actually metastatic at enrollment. Now, PD-L1 expression with tumor area positivity, and I'll explain what that means, were prevalent in both groups at around 60%. Now, in terms of the primary endpoint, let's talk numerically. The overall survival with the addition of durvalumab is 12.8 months compared to 11.5 months in cisgem alone. This was statistically significant with a p-value of 0.02, and the hazard ratio is 0.8 in all comers at overall. So this is the median, indicating a 20% reduction of risk of death with the addition of durvalumab. Now, as you can see, the separation of the curves kind of happens later, after 6 months. So the hazard ratio prior to 6 months is 0.91. However, the hazard ratio after 6 months separates and increases. So, and the hazard ratio comes up to being 0.74, indicating a 26% reduction or risk reduction of death after 6 months. Now, when we look at the 2-year overall survival, we see that almost 1 out of 4 patients who have been given durvalumab on top of cisgem are alive at 2 years, compared to only 10% of those patients who were given cisgem alone. When we look at the subgroups, let's look at which ones actually benefited. You can see that most patients actually benefited based on this forest plot, swaying to the left, indicating that most subgroups were actually favoring durvalumab. However, I want you to pay attention to the primary tumor location. So when we look at intrahepatic and extrahepatic cholangios benefited probably the most, as opposed to gallbladder cancer, which benefited modestly from durvalumab. Now, this is what's exciting, basically, at least for me. Now, when we look at PD-L1 expression with newer trials, with different disease sites, with different immune checkpoint inhibitors, we have different calculation methods of PD-L1 expression. So we have CPS scoring in gastric, we have TPS scoring, and now for our biliary tract group, we have TAP scoring, which is tumor area positivity. So tumor area positivity is basically a new score that looks at the combination of tumor cells proportion that have PD-L1 membrane staining positivity and immune cell PD-L1 membrane staining positivity. So the combination of those is basically what is known as the tumor area positivity. And the subgroup that actually benefited the most is right here. So when you see PD-L1 expression or tumor area positivity of more than 5%, you actually see the hazard ratio being 0.7, indicating a 30% reduction of death in this subgroup. Progression-free survival was also numerically and statistically significant with the addition of durvalumab with cisgem at 7.2 months compared to the control arm being 5.7 months with a hazard ratio of 0.75. When we look at the objective response rate, this was also numerically higher with the addition of durvalumab, and it came about almost 27% compared to almost 20% in the cisgem group. In terms of adverse events, when we look at treatment-related adverse events, grades 3s and 4s, it is almost 60% in both groups. It is numerically slightly lower with the addition of durvalumab compared to cisgem alone. When we look at the types of adverse events, let's focus on treatment-related adverse events. They are mainly our myelosuppression group, so low neutrophils, anemia, low platelet counts, and others. And it was numerically lower in the durvalumab arm compared to the control arm. When we look at immune-mediated adverse events, this is expectedly going to be higher with the durvalumab arm. And most of these events were actually hypothyroidism and rashes or skin toxicity. So in conclusion, and these are the author's conclusion, this was presented in the most latest ASCO, TOPAZ-1 is the first global phase 3 randomized control trial that actually showed a positive result with the addition of an immune checkpoint inhibitor on top of chemotherapy as first-line therapy for advanced biliary tract cancers. It did meet its primary endpoint at the pre-specified interim analysis, and it showed a statistically significant and perhaps clinically meaningful prolonged overall survival compared with placebo plus cisgem. Now, durvalumab did not show additional or unexpected toxicity, and the author's conclusion is durvalumab should become the new standard of care for patients with advanced biliary tract cancers. Now, what I want to show you in the next few slides is where does other immune checkpoint inhibitors lie in the group of biliary tract cancers. Now, this is a publication that is actually quite old, dates back to 2013, and it actually looks at the median tumor mutational burden between different disease sites. And we can see that the tumor mutational burden of intrahepatic cholangios is around 2.7 mutations per megabase. The percentage of ones that actually have a TMB of more than 10% was 5%, of more than 20% is actually 2%. And microsatellite unstable cholangiomas are actually around 1%. Now, biliary tract cancer is perhaps an immunogenic tumor. Preclinical studies show that we do see PD-L1 expression, we do see infiltration of T lymphocytes in those groups. Now, this actually does mean that PD or biliary tract cancers with PD-L1 expression are probably more aggressive. And this actually further confirms the low overall survival in this subgroup of patients. Now, another study found that positive PD-L1 expression on tumor infiltrating T effector cells was actually observed in more than 50% of patients with biliary tract cancers. Now, in terms of other immune checkpoint inhibitors, with the addition of cisgem trials, there have been a few. One of them investigated nivolumab, which I have briefly shown you the results of. One of them is actually investigating a new anti-PD-1 inhibitor, which is toripalimab, in addition to cisgem. This is the waterfall plot indicating some responses. It actually indicates a disease control rate of 85%, which is quite remarkable, and a progression-free survival of more than 6 months. These are some of the ongoing phase 3 trials that are investigating different immune checkpoint inhibitors and different targeted therapies. So I presented to you TOPAZ-1. We are going to look forward to another immune checkpoint inhibitors, which is KEYNOTE-966, adding pembrolizumab on top of cisgem. They are planning to recruit more than 1,000 patients. Other trials, such as IMbrave151, this is a phase 2 trial that actually adds atezolizumab and bevacizumab, which is standard of care now in HCC, on top of cisgem. And the phase 2 trial is ongoing, and it's planned to recruit 150 patients. Dr. Saeed spoke to us briefly about HER2-positive biliary tract cancers, and this HER2 agent is being investigated in a phase 2 trial. Olaparib, or a PARP inhibitor, which has evidence in pancreatic cancer, is being investigated in biliary tract cancers that have homologous recombination repair deficiency, and as well as other combinations. So my conclusions from the talk that I just gave is TOPAZ-1 remains the first positive phase 3 study that actually reported positive results in biliary tract cancers. Now, the benefit was actually higher when PD-L1 expression, or the TAP score, was more than 5%, with a hazard ratio of 0.7, meaning probably a 30% risk reduction of death. And the benefit was noticed to be higher after 6 months of therapy. At the first 6 months, the hazard ratio was 0.91, and after 6 months, the hazard ratio, and as you see, the separation of the curves, was actually 0.74. There are many upcoming studies in biliary tract cancers that investigate the combination of immune checkpoint inhibitors with chemotherapy. And by that, I conclude. Thank you very much.
Last speaker to come up. Yes. Okay, we have a question from the audience. Dr. Fahad Al-Muqbil. Yeah.
Thank you. So my question is to Dr. Saeed as well as the Dr. Samah. It's a question with two parts. The first part is, Dr. Saeed, in reality, do you think we can get the results of the mutation for the gallbladder within 10 days, as you mentioned? Because in reality, different between one institution to another institution, it will take at least minimum, we are talking about 4 weeks. So what I'm doing, I'm not sure if I'm right or wrong, usually in the first line, prior to progression, and we request the NGS looking for those targeted mutation. And my second question for both of you, Dr. Saeed and Dr. Samah, if you can, if you want to hear your input regarding the resistant. I have a couple of patients that they have Fgfr positive. We start pemigatinib. One of them progressed after around 7 to 8 months. what kind of mechanism of resistance we have in those patients, and what's your advice? Do we need to do it again in GS, looking for mutation that change, or what's the next step if the patient's in good shape? Thank you.
Thank you. Great question. So we have a very limited experience, generally speaking. We have limited experience with the gallbladder in general, biliary tract, given how rare it is. But I will give you the experience from the lung side, lung cancer, because it's more cases and we have more experience with that. When we started 5 years ago, it was really difficult, as you mentioned, for many reasons, not just the technology. Sometimes the failure rate is very high with smaller tissue. So repeat is 2, 3, 4 times. Every time we repeat, the protocol itself is 5 days. With more cases, I think the experience is getting better. And I think at least in our lab, the average time now reach around 7 to 8 days for lung cancer. So this is a realistic expectation. The experience with gallbladder, I think, will go through the same tract, right? People need to understand how the tissue will look like, how the failure rate is, and how good is the panel itself. So I would say currently, yes, 10 days to 14 days is a good expectation. But there is also cost-wise. If you don't have a lot of samples for a specific panel, we have to batch, because the one run, costs 50,000 riyal and more. So that also has nothing to do with the patient or the technology or anything. So batching is also part of it. Higher volume means there's more frequent. So I hope this answered the first part. For the resistance mechanism, there is so many mechanisms, and to be honest with the Fgfr, I'm not sure what is the mechanism now, but what I would recommend usually is go with the smallest panel in the guideline. Once they are having a resistance, go for a bigger panel. If the patient is especially young and you think there is a potential for it. This way, you will not repeat the same panel, which is usually clinically oriented and has nothing to do with the research part. So a 300 to 500, which is foundation medicine, and guardians panels. This may shed some light on the mechanism, but usually this is unlikely to shed something. And if it does, it wouldn't really something that's practical in the guidelines. I don't know if Dr. Samah would have anything to add.
Sure. So thank you, Dr. Fahad, for the question. I concur with Dr. Turki. Resistant mechanism, actually, there is a lot of ongoing trials to try to understand mechanism of resistance. Some of the ideas is actually alteration in the receptor kinase or activation of a different receptor kinase, or actually an internal activation of internal pathway. How understanding resistant mechanism will actually impact my current clinical practice. I don't think we have medication to actually work on resistant mechanism yet, but I think it will be in future, it will be like the lung cancer. Once we discover the resistant mechanism, we have a medication that will work on the resistant mechanism and so on. But for now, we don't have actually medication or clear understanding.
Okay. I have one more question for Dr. Turki, which you kind of alluded to. So given in cholangio, we always have issue with as you mentioned, very small number of tissue sample. Would be the first way to go to just a smaller panel, like of 10 or mutation or 10 or a bigger NGS? Like if we have the option, what would be the first one we would send to, given that we have a limited tissue right from the start?
So usually smaller panel means we will use something called amplicon-based NGS. Amplicon is a BCR versus the bigger panel, usually probe.
Yeah.
So amplicon BCR would definitely require less tissue. So I think absolutely go, if it is small, go for the amplicon. If you have enough, go for the larger, if the cost is not an issue.
Yes, thank you.
What about liquid biopsy, Dr. Saeed? And specifically in, just like Dr. Roa mentioned, very frequently we have very limited tissue, and obtaining a biopsy can be difficult. Does this have a role in biliary tract cancers?
Definitely for the DNA mutations, Fgfr, BRAF, IDH, RNA, to be honest, company says we can detect RNA from liquid biopsy. I have not seen it. So Fgfr, I don't think we can detect it yet clinically, maybe research, until the circulating cells, tumor cell itself that we capture, break down, take the RNA, then could be, but it's not yet clinical.
I see. Go ahead.
Thank you so much. So question to you, Kenan, did TOPAZ-1 change your practice, or are you willing to change your practice?
Thank you, Dr. Mohammed. I'm glad that you asked my practice, not everyone else's. But did it change my practice? Yes, it did. And for the sole purpose and the sole reason being, this is the only phase 3 study that actually showed us more than 1 year overall survival benefit. I know the difference is not probably as we hoped for. However, this is the only phase 3 clinical trial that added an immune checkpoint inhibitor with chemotherapy that showed me a result that is longer than 12 months. Now, alhamdulillah, we are lucky to have progressive pathologists in our hospital. I would be interested to know if they can actually do TAP scoring. Not sure also if the sponsors can actually help with this. We like to give drugs with confidence, and we like to predict whether our patients are going to respond. I showed you in the presentation that I just gave that for a TAP score of more than 5%, the hazard ratio of benefit for overall survival was actually 0.7, which is quite remarkable, meaning a 30% reduction of death. So I would be very interested to know whether our pathologists can do TAP scores in our biliary tract cancer samples.
What was the percentage of positive?
So PD-L1 positivity, any TAP score was 60% in the trial.
The same question of Dr. Mohammed to Dr. Kahan. So this TOPAZ-1 change your practice for all comer or for those with a positivity more than 5%? So all comer you are yeah. But I'm not sure about the FDA approval. I think it will get FDA approval for all comer. But in reality, I'm not sure, Dr. Mohammed, Dr. Kanan, if you think it's worth to give it for all comer. Just I want to hear your input, please. Thank you.
And again, I would be very interested and excited to do TAP scoring on patients. I would feel much more confident to give it in TAP score more than 5%. Would I give it to everyone? And would I give it to an elderly male with a performance status of 2, who I know is probably not going to do well regardless? Probably not. However, I would carefully select patients, and I would give it to fit young patients who have this ugly disease with poor prognosis, with a overall survival of less than a year. With the addition of durvalumab, I hope that we can get more than a year.
Okay, any more question? We don't have any question in the QE box. Only one, but it's not really related. It's routine sending all laparoscopic cholesystemic to histopathology. Well, that's a practice. Yeah, okay. Okay, then we'll conclude. Thank you. We had a really great session. Big thanks to our speaker, Dr. Samah, Dr. Karan, Dr. Saida Turki, also Dr. Hamid Al-Ghamdi for moderating this session. With that, we'll conclude. I think we'll have to go to break.
Thank you.
Thank you.
Video's on. طيب بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. Good afternoon, everyone. So we are back for the session number 4 for today, which is a live tumor board. I'd like to welcome my dear colleagues as moderators, Dr. Mohammed Arabi, who we had the pleasure of having him as a speaker yesterday. He's a senior consultant interventional radiologist. We also have my dear colleague, Dr. Saif Al-Thaqafi, who is a consultant in radiation oncology and specializes in GI and sarcoma. And I also have online Dr. Mohammed Shaheen, who is a hepatobiliary consultant surgeon. So without further ado, I'd like to welcome to the stage Dr. Ashwaq Al-Aliyan, who is going to present to us a hepatoma case, and will ask basically the moderators for their opinion.
Thank you, Kenan. This one. Actually, I have 3 cases, which is probably in the similar way. So I don't know, you want it to be interactive after each cases? Okay, so I'll start with case number 1. So she's an 84-year-old lady, came to my clinic with symptomatic abdominal pain, loss of appetite, found to have huge HCC 14 cm. NASH related. She was made no code in one of the tertiary hospital. Her performance was 2, and I thought initially because of the weight loss and because of the disease, she's child A, score of 5. This is her initial scan, a huge mass. And what happened next? Do you want to comment on the scan, or shall I continue?
So clearly, it's a large mass occupying the right hepatic lobe, or the I would say probably more than the right hepatic lobe, or maybe 60–70% of the right hepatic lobe. Looks like arterial enhancing. I don't know about the delayed phases, but definitely it looks like CC based on the arterial enhancement. Given the age and the pickup performance status, probably I would say back to you. Systemic therapy. Okay, I don't know.
And the way we look at things are slightly different as medical oncologists. If she is independent in terms of the activities of daily living, she's 84. I agree, it's a huge, nasty-looking HCC. However, if she's fit for therapy, I would discuss with her the pros and cons of systemic therapy and the pros and cons of best supportive care. And I would have her to make an informed decision regarding what she'd like us to do.
Any portal vein invasion, any systemic disease, nodal, or
I don't think there is a nodal disease, but I'm not really sure about the portal vein invasion. See if there is anything from radiation oncology to be offered in these cases.
So it seemed to be like large size. It depends on the radiotherapy the liver reserve. So which is the liver not involved by the tumor. However, there is some data with relatives now about these big tumors, which should have a downstream, but it is like I think as a palliative options. But I want to listen at this stage and this direction symptomatic.
Excellent. So she was scoped. There is no varices. I started in atezolizumab and Avastin. This is snapshot of her scan, and here her latest scan. I'll take it one by one. This is after 3 cycles. I don't know, Dr. Mohammed, if you want to comment on that. صغيرة صح؟
شوي small, but definitely it's getting much smaller now, and it's less enhancing. This is a very important thing. Probably this is the effect of Avastin and Atezo.
This is after 13 cycles.
Okay, so it's almost like no viable tumor anymore. Yeah. It's just an area of hyperdensity. I don't see any nodular enhancement in the periphery of it. And probably, as far as I can see, the portal vein, it looks patent so far. But definitely a very good response. I would call it probably this is CR.
This is the same that your opinion on the tumor board. I present her because she started to develop skin rash, which I think it's a grade 2 skin rash, but probably immunotherapy related. So I had to hold the treatment, and I was encouraged when the tumor board told me that it looks there is a radiological CR. So I stopped the therapy, and she had the total 17 cycle, and this is the last one. And now she's just on follow-up. She comes every 4 to 6 months.
Remarkable outcome, mashallah, Dr. Ashwag. And in terms of tolerance, in terms of bleeding.
Excellent. You know what happened after 3 cycles? The drop was almost 50% from 14 to 7. And the patient started walking by herself, not coming in a wheelchair. She started eating because the mass was pushing in her stomach. She's feeling heavy. And the skin rash came later after the 17 cycle. So I thought it's the right time to stop. There is no reason to keep her in maintenance since she's elderly. She's coming from the south every 3 weeks. So I give her off and I keep following her up. And the last scan was remarkable. Response, yeah.
Excellent.
So do you have any specific biomarkers to tell which one is going to respond, which one is not going to respond?
Unfortunately, we don't. But so far, immunotherapy probably the most effective therapy. And if you compare it with TKI, definitely immunotherapy is the more effective. Now, the most appealing data, which is about atezobev, it's the height survival and response rate. Honestly, from my own experience, because I treat a lot of HCC, I think we see more of these patients with CR, and I have only 3 cases, but I have more cases that are doing very well on atezobev with a minimal toxicity. I had one patient, he has severe toxicity, he had to stop the therapy, and after 3 months, repeating the scan, he was still responding off therapy. So we don't have a marker, and pseudoprogression, it's not well known as in GI in general, especially like HCC, but you might see hyperprogression on these patients. I saw that initially a lot. Nowadays, I don't know, are we super selective the patient, although all my patients are elderly, so I didn't see hyperprogression yet in my patient. So second case is a 76-year-old male with comorbidity, diabetes, hypertension. In 2019, he presented abdominal pain. It was CT showed cirrhosis. Etiology was non-viral. He had a large HCC. He was having a good performance status, and his child score of 5. This is his initial scan. It's multifocal, honestly. What do you think, Dr. Mohammed?
Well, I can see a very large mass in the right hepatic lobe. Maybe there's another one which is sitting in the left lobe as well.
Yeah.
And his performance status is 1, A5. Is there any portal vein invasion in this case, or you cannot tell? Well, probably I would say the same thing. If we follow the guidelines, we have to shift him to systemic therapy, start systemic therapy. If there's good response, this is it. If there is no good response, probably we can attempt something else. Maybe it will augment the effect of the immunotherapy. But I would like to see the response to immunotherapy based on the program.
He underwent TACE, honestly, yes. I think it was not in our center.
Must have not been you between.
Yeah, no, it's not in our center. I'm sure it was not in our center. Then we repeat the MRI. Doesn't show there is much of difference. I don't know. Do you agree with me? It looks very much similar size. Exactly. So he started the nivolumab. At that time, we did not have atezobev. So starting nivolumab, he started to have high LFT. Though he had high LFT, there is no response on the CT scan. So again, maybe all the oncology will attack me from switching from one immuno to another immuno.
So sorry, Ashwag, the high LFT, was it immune-related hepatitis?
Yes.
You think?
Yes.
Okay.
So I stopped.
And
I gave him a steroid.
What grade?
I don't think it was grade 3 for sure, because I wouldn't reintroduce immunotherapy at all.
Yes.
So I start him, and sometime I ask the patient if they are using herbal, because that can make things worse. So I switch him to atezobev, which is not the standard to switch from immuno to another immuno. And this is his scan. This is the previous, this is the one on the right side, post atezobev.
6 cycles on.
Yes.
It's amazing. Well, this definitely defeats radioembolization.
Would this be the effect of previous TACE?
No, I don't. I don't.
لأنه أخذ 6 cycle of nivo. يعني you're talking about 3 months.
Another 3 months here, so this is 6 months approximately after TACE.
And did he have any complications post-TACE?
I don't think so.
Then it was not done properly.
Maybe. Yeah, I would totally agree with you.
Yes. So
Yeah.
without such a huge mass, post-TACE definitely he would have suffered.
At least from the embolization itself.
Post-embolization syndrome it would have been very, very challenging to treat.
Yeah.
So if any comment?
This is his last scan. Sure, it was first quarter of 2022. So I put some of the data about the prior local regional therapy and the IMPROVE trial. And if you see the patient who received 1 to 2 local regional therapy, if you look at the overall survival was very high compared to patient 0 local regional therapy and even higher for a patient who received more than 1 local therapy. And that's also similar to progression-free survival, that patient who received 1 to 2 local regional therapy, they did well more than 0 treatment, or patients are over-treated like more than 3 local regional therapy.
Yeah, probably what TACE did, it's actually just to trigger the immune response, not necessarily treating the tumor itself, just to trigger the immune response. And nivolumab did the job, probably nivo and then atezolizumab followed. There was one retrospective study I just talked about yesterday. If you start nivo within 30 days after the radioembolization or the chemoembolization, there's significant difference in the response rate and the overall survival. Like I can show you that it's really impressive difference.
Sequential therapy.
Just within 30 days. If you wait more than 30 days, the effect will be way different.
Okay.
So probably the trigger of immune response to by TACE to immunotherapy, this is what it made it a lot different in this case, probably.
I agree. This is the last case. 75-year-old male, performance is 1. Now it's different. It's an early B, child score of 7, multifocal HCC. طبعا هاي الصورة الصغيرة أنا ماخذتها عشان أجمل البرزنتيشن بس هعقدك شوية. But it's have multifocal lesion, right?
Yeah, so as far as I can see in the left, there is a large lobulated mass in segment 2 and 3. Not sure about the right side.
The one in the top left,
yeah,
there is a lesion.
Image, it shows the large mass on the left side, the left lobe. Yeah, if it's isolated to the left side, what's his performance status?
This one. This one. Yeah.
A5?
No, 7. P.
Oh, B7.
B7.
So I would assume he's not very good candidate for like systemic therapy.
I think we've discussed him that let's start systemic therapy. I started him initially in sorafenib, and it did show disease progression on the scan.
Yes.
Then I switched to atezolizumab after sorafenib, and
still progressing.
Yes. No, 400. 400. This is different cut. The one on the left, this is the old one. The one on the right is the new one. Different cut than the other one. It's probably showing the difference. هذا الجديد اللي هو on the right side. أي postal treatment. ممكن اختياري للأفلام not the best. I'm not a radiologist.
Yeah, I would say there is a residual disease probably. I cannot really be 100% sure, but I would say there is residual disease. But I'm not sure how much. If you scroll back and forth, you would see the exact extent of this.
Next time you will do the scan for me. That's the new one.
Yeah.
That's the new one.
Yes, definitely the tumor is much smaller now. And this is post-atezolizumab.
Yes.
Yes, it is. Well, that's very good response, I would say.
This patient, I have to stop the therapy because she started to have symptoms, looks like an early dementia. So I have to stop the therapy. Then after 3 months, patient back to normal because I have another patient who developed dementia on nivolumab and continue to be demented. And we have a third patient, me and Samah, we share. And again, patient started to develop symptoms of early dementia after starting nivolumab. So I think immunotherapy have some role of this, especially in HCC patient.
My question, Dr. Ashwag, is the patient is child PUB7, right?
Yes.
And how confident can we be And remember, we're actually talking to a significant number of audience virtually.
Yeah.
How confident can we be in giving immunotherapy to those patients?
Okay. I think even yesterday we've discussed this with our external speaker. I think it was in sorafenib, we started only with child A, that's it. Then we came to use an early P. Nivolumab on the checkmate, they included an early P. So what will be the difference? I know. And if you exclude all early P, I think you can exclude good bulk of the patient because most of our patients are early P. So early B, it will be different. Patient with bilirubin of 60, different than patient bilirubin of 32. So it's a judgment call, and I think you should see how fit is your patient, how much is the liver decompensation, how much the patient, sometimes patients are not on therapy for ascites. So they will have ascites, but they are not in beta blocker, they are not in diuretics, so you can manage them. So I think the trick, how you can manage the patient, so you can reduce their decompensation, and these patients carefully have to follow them, not like the child A. And I think all immunotherapy, you should see the patient every single cycle because side effect can be early, can be late, can be delayed. So you have to see the patient very frequent to avoid this toxicity and side effect.
I agree with you, Dr. Ashwag. And I agree with you that child B7, they are not a homogeneous group. They're in fact a heterogeneous group.
Exactly.
And if someone has portosystemic encephalopathy and based on that they are child POB7, I would probably label them as best supportive care, and I would not expose them to systemic therapy, as opposed to maybe hypoalbuminemia post an infection or an admission, and it's an acute phase protein, so it may actually go low, and then it may go up. So I agree with you, it's different.
One of them, they were, all of them before therapy, they were okay. One of them, I did not catch him early, honestly. I thought because of his age, and he continued to be even off therapy. That one, he gets back to normal after 3 months of holding the therapy. The other one, we stopped the therapy, and I'm going to present him because he's coming to Riyadh in the tumor part, and he's for local regional therapy because you cannot give them immunotherapy because of the neurological symptoms. So I think I'm going to conclude here, and thank you. Thank you very much.
Thank you so much. So it's my pleasure now to introduce my dear colleague and friend, Dr. Mohammed Al-Garni, who is a GI oncologist and a cancer geneticist. We will be presenting a pancreatic cancer case to this tumor board.
Assalamu alaikum. Bismillahirrahmanirrahim. Thank you very much, Dr. Kanaan, for the kind introduction and for the invitation. So I'm going to share with you one of pancreatic cancer cases. And it's going to be the same like cases of Dr. Ashwag, trying to be interactive. And for technical reason, I couldn't get the image by itself, but I have the reports. Okay, so just one slide about the MDT is important in patients with pancreatic cancer, especially for resectable cases. And one of the studies that looked to the agreement among the multidisciplinary team about staging and resectability of patients with pancreatic cancer, and they found that there is high level of agreement for T, N, and M staging. However, there has been significant variation in terms of deciding about resectability of patients with pancreatic cancer. So my patient is a 62-year-old female, known case of hypertension. She presented to the GI clinic on May 2019 with progressive epigastric pain and weight loss. She had a CT scan that showed pancreatic head mass that measured 2.1 by 3.5 centimeter. Then she underwent endoscopic ultrasound and FNA that showed atypical cell suspicious for adenocarcinoma. Her baseline CA19-9 was elevated around 125, and the patient was referred to oncology clinic. So when we saw her in the clinic, she has excellent performance status. We presented her in the tumor board. The CT showed a pancreatic head mass that invade SMV with subcentimetric pancreatic celiac and portocaval lymph nodes with indeterminate single lung nodule. The pathology, again, in the tumor board is a typical cell suspicious for adenocarcinoma. So this is the impression of the tumor board. The patient has a borderline resectable pancreatic cancer, and the recommendation is for a neoadjuvant chemotherapy. So what do you think, Dr. Kanaan?
Thank you, Dr. Mohammed. Unfortunately, this is not an uncommon scenario. I agree with you that tumor board discussion is essential here, and discussing it with a hepatobiliary surgeon with expertise in pancreatic or Whipple surgery. Deciding on what's resectable versus not resectable has to be done in a multidisciplinary team, and has to be done with the expertise of a surgeon, because the SMV abutment differs between what the surgeon can do and what they cannot do. So I agree with that. Now I know Dr. Mohammed Shaheen is actually on with us, so maybe we can hear his opinion as well.
Okay.
Yeah, thank you. And hello, everybody. I agree actually completely with Dr. Khan and with you, Dr. Kearney. I mean, borderline cases are, although kind of well described in guidelines, or described in guidelines, the opinions, it's not black and white, and depending on how the image actually looked, and the surgeon who's doing the case sees the image to decide if this would be doable or not based on their own and their center expertise.
Okay, thank you. Dr. Mohammed, we have always issue with obtaining tissue from pancreas. This patient, she has fine needle aspiration based on the consensus in the tumor board. We treated her based on suspicion.
Yes.
So, and it's not easy, even in the tumor board, most of the time we cannot get a tissue diagnosis. So just can you elaborate about the technical aspect of not able to do the true cut biopsy from pancreas?
Well, the standard of care is to start with the EUS guided biopsy. But if this is not possible for technical reasons, availability of the device, then percutaneous biopsy is possible. Nonetheless, because of the anatomic location of the pancreatic head, probably we have to go transgastric, transhepatic as well. And you have to remember the area is surrounded by several vessels, major vessels. So we prefer to start with the fine needle aspiration just to avoid any major complications, specifically vascular complications. And we prefer not to do true cut biopsy because of the added risk of pancreatitis, because the more aggressive you go, you add the risk of pancreatitis and possible pseudocyst formation. But definitely it is one possible way to deal with the pancreatic head, even pancreatic body and tail deep biopsies. But because of the anatomic location, sometimes we have to go transgastric, transbowel, transhepatic sometimes.
Okay, fair enough. So anyway, we started here on FOLFIRINOX for 3 months with excellent tolerance to therapy and improvement in her symptoms. The CT assessment after 3 months showed significant improvement with reduction about 75%. Now it's measure 1 by almost 1 centimeter with less encasement of superior mesenteric vein. The CA19-9 is normal. The genetic testing showed no genetic mutation. So Dr. Shaheen, do you think now it's the time for surgical intervention?
I mean, the concern was in the initial scan was the abutment of the SMV, and now it's gone. So yes, I would say it would be the time.
Okay. So the case was presented again in the tumor board, and they agreed to proceed with exploration laparotomy and Whipple surgery. So she was taken to the theater in 2019, and during intraoperative, they found that the SMV encasement is significant, and they cannot obtain the root of the mesentery, and they cannot obtain a venous resection. So the patient was deemed unresectable at that time. So, Dr. Shaheen, how common that there is a miscoordination between the radiology and the intraoperative finding in patients with pancreatic cancer?
Okay, that's a great question. And I think actually things differ from a patient who underwent neoadjuvant versus somebody who is coming just right off the bat for surgery. I think most of the time, the radiological findings would be more or less replicated intraoperatively for patients who did not yet undergo neoadjuvant. However, I don't think it's uncommon to find surprising findings after neoadjuvant chemo, and particularly if it's chemo-rad. I know this patient only had chemotherapy, but it is not. I would say it is not uncommon.
Thank you, Dr. Garni. Yes. Is it how common is it to actually see 75% tumor reduction after only 3 months of modified FOLFIRINOX? And personally, I don't really expect to see this unless the patient probably has a germline mutation or is BRCA BRCA mutated. And you expect some remarkable responses with oxaliplatin.
Yes.
But you did the genetic testing and it came back as negative, right?
Yeah, so I think this is a remarkable response, and this is one of the few cases that I have that they show a remarkable response without harboring any germline mutation. So Dr. Saif, now the patient has locally advanced unresectable pancreatic cancer. Do you think that you will intervene now, or should we give more chemo?
I think the timing of radiotherapy, there isn't like any right answer for that. The volume for us is matter because it is complicated area, as Dr. Arabi mentioned, with other organs and also the duodenum as well. So for us, it depends on the radiology, the anatomy. If it's fit for what we would like to do now is the SPRT, which is the radiosurgery, 5 fractions, easy with the patient, less toxicity, rather than the long chemo with no toxicity. So I would just judge it based on the anatomical appearance.
Dr. Ari, from interventional radiology, any modality that we can offer for such patients?
Well, I was thinking about the same, but I wish I had the access to the images. IRE is one potential option in these cases where you have locally unresectable tumor applying IRE, which is irreversible electroporation. This is typical modality for such kind of cases. This modality is designed to preserve the critical structures such as the vessels or the bile ducts while destroying the tumor itself. But I wish I had access to the images to see.
Okay. So actually what I did, because she responded nicely to chemotherapy, I opted to continue a few cycles of chemotherapy for another 3 months. The CT scan after that showed stable findings. The CA19-9 is normal. And at this stage, I consulted Dr. Saif. And the discussion was about SPRT, as you mentioned, Dr. Saif, versus external beam radiotherapy. The fiducial insertion was not feasible, so the patient was treated with concurrent chemoradiation, 56 gray in 28 fraction with Xeloda. And CT scan after 3 months showed stability of the pancreatic mass with improvement of superior mesenteric vein encasement. So do you think we still should consider surgery in this patient, or surgery is out of the option? Dr. Shaheen?
So just to get this straight, so the CT scan now showed improvement of the SMV encasement. How was that different from the prior scan that also showed the same thing?
Yeah. So there has been
really
improvement. Yeah, so there is improvement, further improvement in the superior mesenteric vein encasement, and after radiotherapy.
Okay, that's a little bit tricky because even the prior scan did show that the SMV was not encased.
Okay.
Correct? Is that correct? Is that my understanding correct?
Yeah, you are right. So I think even laparotomy, maybe exploration laparotomy sometimes in such cases may be considered again. However, in this patient, we opted to observe her after the chemo radiation. And during this time, she was planning to travel to the United States. And she went there and she underwent triple surgery, and they were able to do the venous resection for her. The pathology showed complete fibrosis without any viable tumor. So, Kanaan, what do you think after surgery? Would you still offer anything, or?
So if she had 6 months of preoperative chemotherapy, then I would opt for surveillance.
So this is what we did for the patient. She has been maintained on surveillance since that time. Last time we did CT scan was a few weeks ago, and the patient is still free of disease. This is my case. Thank you very much.
Very much, Dr. Mohammed. Interesting case and good results as always. So it's my pleasure to welcome Dr. Ali Al-Faqih to present to us a neuroendocrine tumor case. Dr. Ali Al-Faqih is a GI and sarcoma specialist who works at and is currently chairing actually the King Fahd Medical City Oncology Department. Dr. Ali.
Assalamu alaikum. Can you hear my voice clear?
Yes.
Okay, great. Bismillah ar-Rahman ar-Rahim. First, I would like to thank the organizing committee. Special thanks to Dr. Ashwaq and Dr. Kanaan for the nice invitation, and the scientific committee for the nice organization. So I have a case here, and I hope I will be interactive like my other colleagues. So our case is a 51-year-old female. She's not known to have any chronic medical illness before. In December 2020, she presented to a private clinic with a 9 months history of increasing right upper quadrant pain that was vague, dull in nature. She also reported intermittent diarrhea, occasional sweating, and hot flashes. Other systematic review were unremarkable. Her past medical history was remarkable for left breast lipoma excision 20 years ago. She is not on active medication and she doesn't have allergy. She lives in Riyadh and has 7 children, and she works. She was a retired teacher. There is no family history of malignancy. Her initial physical examination, she was looking well, not in distress. There is no jaundice or pallor or facial flushing. She has excellent performance status. Abdomen was soft. There was some tenderness in the epigastric and right hypochondrial area. The liver was palpable, around 4 centimeters below costal margin. Other systemic examination was unremarkable. So her initial investigation was done outside our hospital, showed unremarkable CBC, apart from mild anemia, hemoglobin 11, liver and kidney function were normal. Baseline tumor markers, CAA, CA19-9, CA125 were done there and was unremarkable. She had an outside CT and MRI showing multiple liver lesions, and that's why they advised her to go to another hospital. They did for her upper and lower GI endoscopy. The AGT showed only mild gastritis, duodenitis. The colonoscopy was also unremarkable, apart from minimal hyperemia in the left colon, and they thought it might be secondary to preparation. They take also biopsies from upper and lower endoscopy and were negative. So the patient was referred to our hospital. She was seen by Hepatitis team, and the CT and MRI was reviewed with our radiologist, and there was additional finding of well-defined mesenteric lesion measuring around 1.7 by 1.2 by 2 centimeter. It was inseparable from the adjacent small bowel loops. There was also confirmation of innumerable bilobar hyperenhancing suspicious hepatic lesions, most likely metastatic, with largest at segment 7, measuring around 1.7 centimeter. The overall picture was suggestive of metastatic mesenteric/small bowel neuroendocrine tumor. So these are some imaging from the patients. Here is the small mesenteric lesion in this area. This is the MRI showing the same lesion here. And this is the CT scan showed multiple bilobar liver lesions. Okay, so the patient was taken to the tumor board. Additional findings were discussed. Chromogranin was elevated at 783. The hepatobiliary team discussed the liver findings that were unresectable. The octreotide scan showed also multiple tracer avid hepatic lesions and also the well-defined mesenteric lesions, somatostatin avid disease. So I would like to ask the tumor board team, what do you think about the next step in this case? Is this enough for management, or do we need additional investigation?
I'd like to start, Dr. Ali. So for me, this patient has metastatic, probably well-differentiated neuroendocrine tumor. So I'm not sure if, did you mention a biopsy? Was this?
No biopsy done. That's why, because the surgeon brought this case in the tumor board and thought that everything is consistent with neuroendocrine tumor, there is no need for biopsy. And he was actually asking if we can start systemic treatment. So do you think this is enough, or do we need to take a biopsy from this case?
Well,
and probably maybe we can ask also the radiologist if they think that radiology is diagnostic, or do we need confirmation?
So for me, as a treating medical oncologist, I would always ask for tissue diagnosis. And there is still the rare instances where, you know, the disease radiologically looks like something and it is histopathologically something else. So I have an interventional radiologist, Dr. Mohammed Arabi, to comment as well.
So this is not HCC, so we have to treat it as metastatic disease. So we have to have a biopsy in this case. It could be easily metastatic colorectal cancer, or like some different type of malignancy that we are dealing with, not necessarily neuroendocrine tumor. Imaging features of neuroendocrine tumor are not always enough to make sure this is the, unless we do like a octreotide scan and other, but there's so much overlap between the types of metastases.
Yes, agree totally. And let me ask also our hepatobiliary team. Do you think that the patient has multiple bilobar liver metastases? And also there is also primary mesenteric / small bowel tumor. Is there any role of intervention in this case?
Dr. Shaheen with us?
Yes, I'm with you, but I'm sorry, I missed the last part. So what was the pathologist's diagnosis?
So pathology is not yet done, but we have primary mesenteric small bowel mass and multiple bilobar liver lesion. Is there any role of primary intervention like surgery in this case? Either for the primary, or what do you think?
So in general, surgery would have a role, but it needs to be done in a planned fashion with the whole team and with the clear objectives in mind. What do we want to achieve? I think surgery as a curative intervention to take both the mass and the liver lesions, I don't think with your description is going to be doable. But I think after this patient is worked up appropriately and we have a clear understanding of tumor pathology, it can be discussed depending on what this patient can be offered to convert this, for example, to a liver-only disease if this mass is resectable, etc.
Exactly. So that was our discussion, that the patient has only 2 sides of tumor. So we asked our surgical team to go ahead and remove the primary mesenteric small bowel mass. And the aim here is to address the tumor resection, also to probably avoid future complication such as obstruction, perforation, bleeding, if these primary tumor has progressed, in addition to obtain also a tissue diagnosis. One concern here is because it seems that she has functional neuroendocrine tumor, so there is also a concern about carcinoid crisis. So there is a recommendation to give also octreotide therapy to prevent carcinoid crisis as intra-op. So she was initially given the octreotide therapy as preparation for her surgery. Then she underwent resection of the small bowel. It was laparoscopic / open, and also resection of the mesenteric tumor. This was February 2021. And pathology confirmed the well-differentiated neuroendocrine tumor, WHO grade 1. Tumor size was 3 centimeter, mitosis 1, and Ki67 was 1.7%. 4 lymph nodes were negative. And here is the description of pathology, immunostain, showing positive CDX2, chromogranin and synaptophysin, and comment about diffuse positivity of CDX2 favors a mid-gut origin. Okay, so the patient underwent surgery, she recovered well. Then she was referred to our oncology team. She still has a residual liver disease. So we reviewed the pathology, low-grade tumor. She still has diarrhea, hot flashes, and occasional sweating. So what do you think about systemic treatment, Dr. Kanaan, as first-line option in this case?
So somatostatin analogs, Dr. Ali, although I thought this was started preoperatively, was it?
Yeah, the one was started pre-op. It was as prophylaxis or preparation for to prevent carcinoid tumor. But yes, I agree with you. So the patient was started on long-acting octreotide, 30 milligram IM monthly. She has good tolerance to treatment, and her symptoms were controlled. This is just a short summary about the first-line treatment of metastatic and resectable well-differentiated neuroendocrine tumor. Both octreotide and lanreotide has been shown to be highly effective in controlling the symptoms of hormone secretions, and also in controlling the tumor growth in terms of delaying tumor progression. So this is just summarizing the outcomes of these two results, PROMID with octreotide and clarinet with the lanreotide, improving the progression-free survival. However, the overall survival is not statistically significant, but the most important thing is progression-free survival. Okay, so her follow-up in June 2021, about 5 months, octreotide scan shows progression of the tracer-avid hepatic lesions, and the advice for PET gallium-68 scan. However, the radiology, other radiology like CT scan and MRI showed stable bilobar hepatic lesion. There is probably one new lesion in segment 3, but it was very small to be characterized. So I would ask our radiologist, so do we have like this discordance between the metabolic, or let's say nuclear radiology and conventional radiology? Do we depend on one modality, or just combine the two modalities and take a conclusion from those?
Well, one possibility is the tumor is dedifferentiating or changing its pathology. That's why you see interval progression of the FDG avidity, not FDG, octreotide activity. Maybe the tumor is stable in size, but it's dedifferentiating. That's one possibility. Not sure if this is known.
So for certain neuroendocrine tumors, if you have oligo progression versus full-blown systemic progression, I think it differs in terms of management. If I have oligo progression, meaning one single liver met increasing in size and becoming more aggressive, and everything else is stable, then I would probably ask my colleagues from interventional radiology or even the surgeons to think about some local therapy for this active lesion. So that's probably how I would approach it.
Did you consider biopsy?
Yes, I totally. Sorry?
I mean, would you consider repeat biopsy in these cases when you have a discrepancy?
That's excellent question. So at this stage, since it was just mostly stable disease, and this new lesion is not it was probably a new lesion, but it was not confirmed, and we don't have. We thought that we might have another follow-up to confirm if it's progressing or not. So let's see here. So she was clinically stable, and she actually improved, her symptoms improved, the area flushing, but she was concerned about the new result. The overall picture was stable disease versus mild progression. So we discussed the option of either continuing the octreotide therapy with close observation or starting additional therapy as a second line. So here we started everolimus, second line treatment, and continued on octreotide therapy. The aim here is also to control her symptoms. So one thing was reassuring is her chromogranin was coming down, 142 from 783. So that was probably reassuring for us that she was not really progressing. What do you think, Dr. Kanaan, about second line treatment here?
I think it's totally appropriate. That's what I would consider with mTOR inhibition. And as long as her symptoms are controlled, I agree with you. I would continue the octreotide. And what's reassuring is that her chromogranin A is actually also coming down.
Okay, that's great. So this is just summaries of the evidence for everolimus. This is the RADIANT-2 showing improvement in progression-free survival as compared to octreotide alone. And the RADIANT-4 everolimus versus placebo again showing improved progression-free survival. There was a trend toward improved overall survival, but it was not statistically significant. I think this is, I mean, in most of the studies for well-differentiated neuroendocrine tumor, the overall survival was not confirmed in most of the studies, only progression-free survival. And one explanation is probably because of the prolonged or slow progression of these tumors. Okay, so she tolerated the treatment very well. Her lab showed elevated hemoglobin A1C and also elevated liver enzymes, lipid profile, which were documented side effects of everolimus. She was started on metformin and lipid lowering agent. At that time, we have the gallium-68 PET scan, which showed the same finding of the widespread gallium-68 to detect avid liver metastasis in keeping with known metastatic neuroendocrine tumor. There was no signs of residual or recurrence in the mesenteric disease area. So only the disease was limited to the liver at this time. So these are the imaging, is just showing you the finding of the gallium-68 PET scan. And maybe Dr. Mohammed, if you have an idea about interpreting this nuclear scan.
Well, multifocal gallium-68 avid lesions throughout both lobes. I don't see any extrahepatic disease, so it's liver-limited disease for sure.
Yes, agree. Thank you very much. So she continued on the same treatment till November, about 6 months, but now she started to have side effects, more side effects, menorrhagia, oral dryness. Her hemoglobin was 8.5. So we held the everolimus, but we continued the octreotide. She was seen by gynae team. Her scan of the pelvis showed ovarian hemorrhagic cyst. There was also subserosal uterine fibroid. Workup was unremarkable about from this finding. So again, we brought her in the tumor board, given that she has liver-limited predominant disease. So what could be the option here for this patient? What do you think, Dr. Interventional radiology, Dr.
So one possible way to deal with these patients who have side effects of this systemic therapy and persist to have symptoms may be bland embolization. That's one possibility. The other option is probably radioembolization, but I would probably start with the bland embolization first and see how does the patient progress. Usually you have to probably do bilobar treatment in order to relatively control all of these regions at once.
Yes, I think that was the same recommendation from the intervention radiologist, that this patient is candidate for local regional therapy with the embolization. So, and he was recommending actually chemoembolization in this case. But he also, we advise that she will need also preparation to prevent carcinoid crisis. So she was admitted in February 2022. We gave her preparation with octreotide injection. She underwent TACE with doxorubicin with lipiodol and recommended to repeat scan in 2 months with continuation of octreotide therapy. So what do you think about the agent here, the chemotherapy agent, doxorubicin, with the addition of lipiodol? So,
well, the data is not really, doesn't show much difference between bland embolization and chemoembolization for HCC. So not to say about neuroendocrine tumors. So the bland embolization is probably equally effective to chemoembolization. Probably there's no point of adding chemotherapeutic agent to the bland embolization. What we are trying to do here is not to control the or to treat the tumor. We are trying to limit the hormonal effect and the side effect from the tumor itself. So we're not aiming for cure here. We are aiming for symptomatic relief. So adding chemotherapeutic agent probably will not add much in terms of response. Probably just simply embolizing the tumors will reduce the side effects of the and systemic side effects of the tumor.
Yes, thank you, Dr. Mohammed. So just one slide about prevention of carcinoid crisis. As we all know that it's life-threatening condition that can result from release of an overwhelming amount of biologically active compounds from the tumor that may be triggered by tumor manipulation like biopsy, surgery, or by anesthesia. And symptoms include hypotension, tachycardia, flushing, and shortness of breath. And usually preparation with octreotide like 300 to 500 microgram can be given pre-procedure in addition to a standby dose as needed during the procedure. So what about the role of nuclear medicine therapy in neuroendocrine tumor? Maybe one slide, and I will ask our colleague also. So we know that GI neuroendocrine tumor who progressed on long-acting somatostatin alone and who are not eligible for liver-directed therapy with preserved renal and hematological function are candidate for PRRT using the radiolabeled somatostatin receptor analog. So this was shown in the NETR study where a patient randomized between the lutetium-177 dotatate versus higher dose of octreotide, showing improved progression-free survival as we can see here, and the trend towards improved also overall survival. So let's ask my colleague, Dr. Kanaan, also our intervention radiology, what do you think about the nuclear therapy here with the PRRT? Is it like standard of care second-line treatment for all patients or for selected patients?
So it's definitely for selected patients, Dr. Ali. We had a very nice talk this morning by Dr. Miad, who's a nuclear medicine consultant specifically on PRRT. Now, I know one of the major contraindications is bony metastatic disease, which your patient does not have. However, one of the relative contraindications is significant metastatic burden in the liver. I think or presumably because of toxicity if you have innumerable liver metastases. So is it for everyone? Definitely not. It is for selected patients and they can get good responses. If I remember correctly, the progression-free survival was remarkably high with lutetium dotatate in the NETR1 trial.
Yes, I agree totally with you. And also in some cases with the liver-limited disease, where they are you're planning to do liver-directed therapy, probably you go for that first, and if they progress, then probably they will be candidate for nuclear therapy. So this patient, we repeated her imaging after TACE, and it showed significant improvement in the size and number of the hepatic lesions. From one, largest was 1.6 as compared to 2.3. Some lesions has also disappeared, and there was also no new lesions. She, in follow-up clinic, she was doing well. She continued on monthly octreotide injection. Her menorrhagia has stopped, hemoglobin normalized, and here her also hemoglobin A1C came down to 6%. She has no new complaint, and she is booked for her next scan in September 2022. With that, I will conclude my case. Thank you very much for listening.
Thank you very much, Dr. Ali. Thank you very much, Dr. Ali, for an excellent case, as always. Now I'd like to welcome questions from the attendees or the virtual attendees. Dr. Mohammed Al-Garni, do you have any questions for the panel? So any of you have any questions? So I'd like to take this opportunity and thank Dr. Ashwaq Al-Layyan, Dr. Mohammed Al-Garni, and Dr. Ali Al-Faqih for presenting their excellent cases. And I also would like to this opportunity to thank Dr. Muhammad Arabi, Dr. Saif Al-Thaqafi, and Dr. Muhammad Shaheen for moderating these challenging cases. I also would like to take this opportunity and thank all the virtual attendees. We have come to the end of day 2 of the this hepato and pancreatobiliary masterclass. Thank you very much for attending. I hope you found these 2 days helpful, and I look forward in seeing you in upcoming events. Thank you very much and have a great day. And I would like also to thank our sponsors for continually supporting these